Thank you. I cordially invite following dignitaries to the head table. Dr. Lal Panapitia, Acting Director General of Health Services. Dr. Susi Pereira, Deputy Director General of Public Health Services. Professor Sanath Lanarol, President, Sri Lanka College of Obstetricians and Gynecologists. Professor Guani Lienege, President, Sri Lanka College of Pediatricians. Dr. Chitramalidi Silla, Director, Maternal and Child Healthcare. Thank you. I cordially invite Dr. Chitramalidi Silla, Director, Maternal and Child Health, to do the welcome speech.
Ayubowan, very good morning to all of you. I am happy to do the welcome address at this very important occasion. We are ending the year 2022, disseminating the findings of very important events, very important databases that we have had during the past few years. So it's my pleasure to welcome all of you for this important occasion. First of all, I would like to welcome our Acting Director General of Health Services and the DGMS, Dr. Lal Panapitia. I know you have a very busy schedule today, but anyway, you make it happen and to inaugurate this meeting and also to give your inputs for policy making. That is very important in this area of review. And also the Deputy Director General Public Health Services, Dr. Susi Pereira, warm welcome extended to you for your generally the guidance given to total MCH program and also in this difficult situation, especially for nutrition interventions, and also chairing all the technical advisory committees of the Family Health Bureau and giving your technical guidance, and also be present today to give your technical inputs. Thank you very much for your presence. And also the president's professional colleges are very, very important in our activities, in our improving the quality aspect of our program. Dr. Sanath Lanarol is the president of the Sri Lanka College of Obstetricians and Gynecologists and the team from the college. So really appreciate your contribution. I think we have done a lot during this year with the support of the College of Obstetricians and Gynecologists. Your leadership was very important for us during this year, and also we continue to get the support over the years. Thank you very much for your participation and also contributing to this event immensely. And also the Sri Lanka College of Pediatricians and the Professor Guani and Professor Shamin is due to come. So warm welcome is extended to both of them and also their members of the Sri Lanka College of Pediatricians and the neonatologists, so who are doing a wonderful work with the Family Health Bureau. And also I really recognize the importance of provincial health system. So we have the provincial directors of health services representing many provinces today and their teams. The regional directors of health services, consultant community physicians, medical officers, maternal and child health, and also the divisional MCH teams. So thank you very much for your contribution, and you are the people who are implementing the program. So your support is very much needed, and also the heads of the institutions. We have a curative arm for reduction of maternal, newborn and child mortality. The curative arm is very, very important, and the presence of the hospital directors and the relevant staff of the hospitals is very, very important. So thank you very much for your participation today. And also the World Health Organization, we were expecting the representative Dr. Alakasin, but unfortunately she is unable to be present today. But representing the WHO, Dr. Manjula Dhanansurya is here with us, and I thank the WHO for their technical and the financial assistance for this all the activities that we are presenting today. Thank you very much for your contribution. And also the consultant community physicians and the university, academia, the CCPs, senior lecturers who are present here today, and also my own staff. I think I have to thank Dr. Kapila Jayaratna, who has been instrumental in implementing these today's activities very much. He had to do a lot of technical work to get this out. So I thank Kapila and the team, and also the all the consultants who are in charge of the national programs and who are doing a very wonderful work, especially during this critical period. So once again, I warmly welcome all of you. And also it is very important that we look back what we have done during the past few years. So I think today we will be discussing about the maternal and feto-infant maternal death review mechanisms that has happened, and we have done a review on that, and also the infant mortality analysis was also completed with the support of WHO and the College of Pediatricians. Then we had the learning from maternal deaths. There were a few models that we studied: qualitative data analysis of maternal deaths, maternal suicides, and the maternal autopsies. So we will be discussing all these activities and all these concepts that we have attended, and also the dissemination of these findings are very important because we have to take some actions based on this work. So what are the gaps, how to implement it? So the participation of all of you is very important in making recommendations and also to make it happen. So that is why we wanted all of you to be together today and to discuss about the future actions. So once again, I thank all of you for your physical presence today in spite of many issues and being the end of the year, having busy schedules. So thank you very much for your participation. I wish the today's workshop a success. Thank you.
Thank you, madam. So I had to be the compere and the presenter both. I will be starting with the evolution of maternal and feto-infant death surveillance and response systems in Sri Lanka. So a pregnant mother is the most precious life of a society. A maternal, fetal or infant death is a tragedy. So we all know the value of all these lives. That is why WHO has recommended counting and reviewing maternal deaths, stillbirths, and neonatal deaths. Sri Lanka, we started counting maternal deaths and stillbirths far back in 1847 with the enactment of Registration of Births and Deaths Acts. And in 1881, we had a documented maternal mortality ratio of 21.7 per 1,000 births, not 100,000, 1,000 births. That came to about 1,623. definitely it may be an underestimation. In 1901, we started publishing maternal mortality data. And not only maternal mortality data, even stillbirth. So that's the beauty of our country. Registration of stillbirth, we started in 1885. And this document, published in 1914, when a professional group wanted a definition for stillbirth, we are there. We already had a documented definition of stillbirth. So it clearly says that Sri Lanka is the only country having a working definition of stillbirth. So we started counting or reviewing maternal deaths far back in 1959, when the Ministry of Health, those days it was called Health Department, they started the pilot project on maternal and neonatal death reviews in 1959. Then in 1981, we started systematic maternal death reviews, thanks to Dr. Joe Fernando and also from the UNICEF, Dr. Hiranti Vichemana. So it was an appendage to the ongoing EPI reviews. Then in 1985, we made it a gazetted event that should be notifiable. So in 1995, structured review of maternal death started under Dr. Vinita Karunaratna and Dr. Anomanchaya Tilaka. Then 2000 we had a National Maternal Death Database. Believe me, before that we just started a CR book at Family Health Bureau just to write down maternal deaths and details. In 2009, so we made it mandatory to do a post-mortem for all the probable maternal deaths. That made a huge difference. So in 2010, after this war and all, so Family Health Bureau designated maternal death review to a national program manager. So actually that was me, and I was given all the technical independence from the Director General of Health Services up to my immediate boss director. So it was a wonderful era that I could think innovatively on the process and restructure the ongoing process. So we tried over these 12 years in our best to improve the data generation, data origination, and also the receipt of these formats, then the how to gather these data in a wider, covering wider area, including all the socio-demographic determinants and also the clinical parameters. So that's why we could get all the bed tickets, clinical records, and other documents. Then at central level, we looked at the data gaps. And so even though it was postmortem so made mandatory, it was not implemented properly. And even the case scenario we had a lot of data gaps and all. And national desk reviews, timely conducting district reviews, then the participation issues, and how to get down other experts. Now, you know, I mean, it's not only public health or obstetrics, but there are other people involved, maybe cardiologists, maybe physician, maybe the anesthesiologist, a lot of expertise. Then the other thing is the action. So is public health surveillance is not just data. So we have to get it translated into action. So we focus more on action, and also the introduction of the immediate response to maternal deaths. So because of our efforts, we reintroduce, we all the guidelines, all the instructions on conducting postmortems, and also we issued circulars even to coroners to make it 100%, both in English, Sinhala and Tamil languages. And with the thanks to College of Forensic Pathologists, we wanted this data, I mean, how it's sometimes very difficult to get a postmortem report. So we made it, what we want is data, not the legal document. So we made a concise report. I must thank Dr. Vaidyaratna. So he actually initiated this, and we introduced this concise report on postmortems. So thanks that all these efforts, you will see how the conducting postmortems on maternal deaths improved, 96%. Dr. Lanrol will present that 2020 it came up to nearly 100%. Just in one case, we couldn't do the postmortem. Then I was talking about comprehensive data compilation. So it was only the formats we received from field and hospital. Then we got down bedhead tickets just to work out timely sequence of what has gone wrong, what has happened, and look back on the other determinants also with regard to each and every maternal death. Based on that, we compile case scenarios. So I think there are many of the reviewers here. So basically, each year by year, I mean, it's not an easy task. So gathering all the information from the field records, hospital records, other postmortem reports and other reports, and compile a case scenario. So this is going to be the subject of review. So it was very easy for the reviewers to do this. It's a systematic compilation of data. And this was the first desk review. Before that, there was no desk review. So because all these specialties cannot go to the district level. So that is why we introduced desk reviews at national level. Before we go to a particular district, we conducted these desk reviews in the particular, taking all the cases. And you see the people there, Dr. Ajita Vijayasundara, always he had been there, and the other specialties, how it was represented then all. Then there was a issue with conducting national maternal mortality reviews at district level. So we went to each and every district every year. 12 years consecutively, coverage is 100%. We reviewed all the cases. So basically, it came to about 1,520 odd cases. So it was represented by many of the healthcare administrators, clinicians, college president of SLCOG, consecutively all 12 years, almost all presidents supported us and contributed to this process because they made it a high priority. So I can still remember Professor Harsha Senaviratna, a key person in introducing maternal death reviews. So we was involved in Colombo death review. So then we thought, now when we discuss maternal death in a particular district, say last year January we had a maternal death, so we may be reviewing it death this year September, December like. So it was a long time lag. So sometimes the context may have been different. So then we thought that the action should be sometimes immediate. So we introduced immediate response to maternal death with the participation of all the caregivers and also the in the presence of Director General of Health Services. So it made a big impact on the taking actions immediate. So we could do a lot because all of a sudden in 2019, our maternal deaths number increased. It went up by 27 odd number. So we thought of at national level. So this is high time we need to focus on immediate action as well. So there were many outcomes out of immediate response to maternal deaths, and we translated these actions. And thanks to the all the efforts of all the predecessors and all healthcare administrators, healthcare obstetricians, our public health midwife, MOH, the provincial, regional level health administrators, our national program managers. This is how the number of maternal deaths went down. It's a remarkable achievement. Not only that, even the maternal mortality ratio came down. So once it was thought that we are in a difficult period, it's stagnating, but we are not happy with this achievement. Still, we have a lot to do, but basically, it made a lot to reduce maternal mortality in this country. So now, we are in a stage of obstetric transition, where our, it is called the stage 4, fertility rate coming down, direct maternal deaths coming down, and indirect causes coming up. And the other causes, now this year you will see, I mean, even malignancies coming up as maternal death. So it's a period we have to undergo difficulty in reducing maternal death. So this shows our system far back in 1881 up to 2020. We have quality maternal mortality data. So when I presented this at international level, they were surprised, being a low and middle income country and investing very little on health and especially on maternal care, but how we are doing this wonderful outcomes at the ground level. So you know the maternal death surveillance and response mechanism in Sri Lanka, and the perinatal death. There was only one data source, civil death registration. So these estimations were provided by Registrar General Department under proclaimed areas, and it did not reflect the country actual situation. So that's why in 2006, Perinatal Society, College of Obstetricians, College of Committee Physicians, Family Health Bureau, all got together and introduced perinatal death reviews. So basically it's at hospital level. So monthly they conducted perinatal death reviews. There is no data flow coming to the central level, and the outcome was shared with Family Health Bureau and the Ministry of Health. So in 2014, we thought now this is not going to do better. So we need individual data. So we tried introducing a paper-based individual data collection system, and 2015 we could do an analysis and come up with some meaningful, so valid data on stillbirth rate. It came to 5.3 per 1,000 births. The next step we thought of, now it's stillbirths. Now we have to go further step, including infant deaths. So many of our large chunk of infant deaths are concentrated in the early neonatal period. That's why we did perinatal death. So now it's high time to go into individual death, infant death analysis also. So thanks to College of Pediatricians, I have to mention Professor Sujio Amarasena and the council. Those days we piloted this in Southern Province and Western Province, and we came up with a national fetal-infant mortality surveillance system, both at the field level and the hospital level. So in 2015, so we want to link this with the civil death registration system that is considered as the gold standard, and we made it from the ministry. We sent a circular that it's mandating all the stillbirths should be issued with Mala Uppanna Sahathike or certificate of stillbirth. So it achieved 90% coverage. In 2016, WHO introduced ICD PM classification. So objectively classifying perinatal deaths. So that is why, in line with that, we could introduce individual perinatal death data collection format, which is data coming to central level. So in 2017, we started pathological postmortems and guidelines. We gave equipment also. In 2019, we went for a web-based system on perinatal deaths. In 2021, this child mortality global report came up, and the worst was reported from Angola, 157 deaths per under 5 deaths per 1,000 live births, and Sri Lanka was ranked number 54. It was, I mean, good position considering the low and middle income country settings. So world best is 2. So it's now we have to focus on achieving this. That's why we 2021 we tightened the central level monitoring of infant death reviews, and I got the good support from the College of Pediatricians. I have to appreciate Professor Chairman Rajendrajit, so, and Professor Guani Lienege. So we first time we had national death reviews of pediatric deaths in Sri Lanka in 2021. 2022, so we wanted to go further step upwards, introducing, expanding the death surveillance to cover child deaths, and also having a population-based stillbirth register, which is the next level we have to achieve. So this year, so we are doing it with all the difficulties, COVID situation and economic crisis, but so far we are doing well in this regard. So all these processes are governed by the Ministry of Health, owned by the Ministry of Health, and well supported by all the professional colleges, and we have clearly spelled mechanisms supported by the circulars and other guidance material, and we involve all the government and private sector, and also the community healthcare sector. And I think we started with it as a public health initiative, and we could maintain the central level grip, and that's why I think we could achieve all these outcomes. And we always maintain a good review atmosphere, no name, no blame, and confidentiality assured environment, and it's non-threatening environment, so for free discussion. And so that is why we could get all these outcome, meaningful outcome for utilization. And public health surveillance is data for action. We disseminated all these data in our minutes, and we publish periodic data analysis on maternal deaths and also perinatal deaths, and wider dissemination from starting from the 2011-12. So we did lot, and we went to media. Because delay 1 was the number 1, more than 50%, and action focus initiatives, we could do lot to translate these lessons into practice. So with all these things in 1981 to 2020, nearly 41 years, I always say all the gulls and mules, so we could achieve lot. And BJOG, British Journal of Obstetricians and Gynecologists, they recognize our system as a best organized and structured system. Not only that, WHO last year, Sri Lanka's system recognized as a role model to replicate in other settings as well. So we, in our strategic plan, we need a country where no preventable deaths of mothers, fetuses, and newborns could happen, where every pregnancy is planned and wanted, every birth is celebrated, and women, babies and children survive, thrive, and reach their full potential. So for that to achieve, we need to prevent preventable maternal and fetal infant deaths. So we want to achieve, we want to target zero maternal and fetal infant deaths. So that is why we need a change. That is why we should do Aragalaya within our settings. So we need all of your support. So let's work together and do something meaningful for the entire country. Thank you so much. So next agenda item is findings of the maternal death reviews of the year 2020. So we did a wonderful job with the College of Obstetricians and Gynecologists taking the lead role, and also well supported by the other professional colleges, College of Anesthesiologists, College of Forensic Pathologists, College of Internal Medicine, College of Surgeons, College of Neurosurgeons, College of Psychiatrists. So all of them got together and we reviewed the year 2020 maternal deaths. So I cordially invite Professor Sanath Lanrol to disseminate the outcome of the maternal death reviews in the year 2020.
Chairperson of head table and members of the head table, dear friends, good morning. Thank you very much, Kapila, for inviting me for this National Maternal Mortality Review 2020. That is 2 years ago what we have done as a team. As Kapila mentioned, these are the desk reviews. So earlier what we have done is we went to districts and had the reviews of each district. But the unfortunate incidents happened in 2020, that is COVID-19 pandemic. We couldn't visit the districts. As a college, I had to take a decision of how we analyze this data in collaboration with Dr. Chitramali Silva and Dr. Kapila Jayaratne, how we do this now. It is a challenge. Taking the challenge, we decided to do it as a desk review with the support of all the other professional colleges. What I am presenting today is the results of those desk reviews. So there are numerous professionals joined with other colleges also. With my due respects to all the other colleges, colleagues, and those who have involved in this. This is the report of 2020. This is the latest report what we are having. I don't know whether it is pleased or whether I am not happy to present that there are 89 deaths happened. Any maternal deaths count for us. The SLCOG, for the SLCOG, every maternal death counts. Our policy is to reduce the maternal mortality and morbidity in the country. So even 89, we can be happy that we have reduced the maternal mortality, yet the 89 mothers died out of 300,000 live births in Sri Lanka. So this is the district representation, and the highest number of mothers died in Gampaha district, that is 10 mothers. And all the other, I think it is clear, I need not to repeat the things. And the most notable thing is Vavuniya, Mullaitivu and Hambantota, there are 0 maternal deaths. So that is a very good achievement for those districts. All the other districts also, thank you. All the other districts also, it is very, very small in numbers have died. So we are happy what we have done as a team. This is in relation to 93 deaths happened in 2019. These are the number of maternal deaths from 2001 to 2020. As it is evident, you will see there is a gradual decline of maternal deaths, but the last 4 or 5 years it is static. So this is the area we have to work. As a SLCOG, we are planning to reduce this maternal mortality to single digit in future. That is our plan. The maternal mortality ratio, as everybody knows, it is the number of maternal deaths per 100,000 live births. When you put this 89 into 300 and 1,706 live births, the national maternal mortality ratio for the year 2020 is 29.5. So this is a remarkable achievement in the year 2022, facing with the challenges of the country. Then the progression of national maternal mortality ratios from 2001 to 2020 is evident in this graph. So here also 2017 to 2020, it is staggering around the magical figure of 30. But in 2019, there is a slight reduction of maternal mortality ratio when it take as a ratio, but not in numbers. This is a district distribution. 2020, it is hard to believe that Matara tops the graph. In the Matara district, it is double the national average. It is 60 per 100,000 live births. And the lowest is Galle, that is 11.3. I'm not going to reading this list, and Hambantota, Mullaitiva, Vavuniya, I have mentioned the 0 maternal deaths. So it is distributed among 60 to 11.3, all the other districts. So leading districts in the year 2020, Matara, Mena, Batiklo, Gampaha and Matale. There were 14 districts that have recorded higher than the national maternal mortality reviews. So what we have to focus our attention on these areas. Yesterday, college had a very successful safe motherhood program at the base hospital Kamburupitiya. We went to Matara, and the interest for learning was immense. There were 390 participants attended for that, and we have identified problems what they are facing, and I want to discuss that in person with the Director General of Health Service and the Director of Family Health Bureau in coming days. I think I'm sure we can help Matara to reduce the maternal mortality ratios. As Kapila quite rightly mentioned, we came to the conducting postmortems. In the year 2012, it was 92%. 8%, somehow or other, we couldn't carry out the postmortems. But we are quite progressed in the year 2020. 99%, that is very remarkable achievement, we were able to do the postmortems and find out the correct cause. Then it is quite interesting, I am moving into the causes of maternal death 2020. It is sad to say, obstetric hemorrhage tops the list. In previous years, it was the respiratory diseases, cardiac diseases were among them. But for 2020, the obstetric hemorrhage is the leading cause. This is in comparing to the 2019, it was heart disease. So there is a remarkable improvement of management of cardiac disease complicating pregnancies in the year 2020. I'll go back to this slide. This is the causes of maternal death in 2020. The heart disease has come to the second. The respiratory diseases pushed down to the third place, and central nervous system related disorders and fourth, and the other important fact is ruptured ectopic pregnancy has come to the fifth place. All the other cases have come down. So 2 to 3 years ago, it was the liver disease that topped the list, but now we have managed it successfully through inclusion of guidelines and awareness programs and the workshops. So now liver disease has come towards the bottom, especially the management of fatty liver in pregnancy. That was the leading cause of death 3 years ago. This is the cause-specific maternal mortality ratios 2001 to 2020. So as in the olden days, that is 2008 and 9, it was a hypertensive disorders. Pregnancy-induced hypertension was a leading cause. Then it moved into obstetric hemorrhage, amniotic fluid embolism, and ectopic pregnancy, liver disease, and miscarriages. This is the cause-specific maternal mortality rates from 2001 to 2020. As you see, 2011 to 2017, it was the respiratory diseases were troubling us too much. But later heart disease, and then it was taken over by the PPHs. These are we categorize the maternal deaths. There are direct maternal deaths, indirect maternal deaths, and undetermined causes. So the majority was direct maternal deaths. There were 46 deaths happened in 2020, that is 52% of the total amount. And indirect causes were 42, that is 47% of the total deaths. And 1%, there were no cause we can find. The timing of deaths is quite interesting again. The postnatal, 52 mothers died, and that is the 58% of the total amount, and which was happened in the postnatal wards or postnatal periods. The timing of death is other post-abortion, 13 deaths, and that is 15% out of the total number, and 24 mothers died during the antenatal period, that is the 27% of the total amount. Then we observed there is a seasonality also. There were high number of cases in December, May, and March that was observed. This is the ethical diversity. Sinhala, 60 mothers died, and that is 67% of the total number, and 20 Tamil mothers died, and 9 Muslim mothers died. This is the sector-wise. The most number of deaths were rural. That is 76% of mothers were from rural areas. And the urban is 18% from the urban sector, and estate sector, it is 6%. I think there's a remarkable reduction from estate sector deaths. Then on the marriage wise, the unmarried were 2% and living together 1%, and 86 mothers died, that is 97% those who are married. This is the distribution of age group. And 31% of them were more than 35 years. So this is very important. The primaries comprise 24%, and the P2s 17%, P3 22%, P4 19%, and grand multiples 8%. So 31% of them were more than 35 years, and 49%, that is nearly 50%, were more than P3s. So when we making the policies, we have to focus on these areas. This is the other area we noticed in the year 2020, unmet need of family planning. There are 25%, there was unmet need of family planning. And this is the area we have to work out a lot. And there were no unmet need for family planning in 75%. 22 deaths could have been averted if we had the opportunity to contraceptives or easy access to contraceptives being promoted in time for the needy women. Period of amenorrhea completed before delivery or death. Most number of deaths have happened more than 28 weeks. Less than 12 weeks and 12 to 28 weeks were small portions happened. The mode of delivery, the most of them were cesarean section related, that is 42.7% were cesarean section related causes, and 34% miscarriages, normal vaginal delivery 10%, assisted vaginal delivery 4%, and unassisted vaginal delivery 2.2%, and the hysterectomy 5.6% consist of this total number of deaths. The place of death, it is very interesting, 84.3% happened in hospitals, and 10.1% on admission death, and 2.2% home deliveries, and on the way to hospital 3.4%. So this indicates it is most number of deaths happen in the hospitals. The type of hospitals, when we dissect it, the base hospital, district general hospitals, 37% happen in these sports hospitals. Then teaching hospital, provincial general hospitals, 60%, and private hospital 1.3%, and the peripheral hospital 1.3%. So according to this, most number of deaths happen in teaching and provincial general hospitals. That amount is 45 mothers. When we analyze in the traditional three delay model, in 46 cases there were delay. The delay 1 is seeking care, delay 2 is reaching care, and third delay is receiving care. So delay 1, while seeking, 33 mothers have died. Then the reaching, 2 mothers have died, and the delay 3, 20 mothers have died. Then what is the preventability? Most important thing is preventability. According to this analysis of 2020, the 20% were inconclusive about the preventability. 33% were unpreventable. Anyway, it's happening. And very importantly, 47% were preventable according to the analysis. What are the issues based on these statistics? These are the issues we found. Delay in seeking care due to multiple reasons at home level, ignorance, and not complying with the PHMO medical advice. This is very important area. The next years to come, we have to improve. Delay in seeking and initiation of care due to fear of COVID-19 or enforcement of curfew. These are the challenges we face those times during the curfew. So the public was scared of curfew and the COVID regulations. So because of that, there was a delay in seeking care. Unplanned pregnancies and multiple issues in promoting contraceptives to needy and vulnerable women were that this was hampered during the COVID-19 time. So that is why number of abortions were high and there were unmet needs were high during that time. There was a notable substandard care at individual and team level in managing index cases at the field, first contact, hospital levels. And when we analyze, there were certain cases where non-adherence to the guidelines, objective assessment of cases, and failure in communication and late involvement in the provision of care were identified. Then the other factor we identified is not providing proper multidisciplinary care in the management of critically ill women and unavailability of required medications, facilities or other logistics at hospital levels in the managing sick women. Vulnerable reproductive age females were not followed up or provided with targeted care by the field teams. Several maternal suicides, although not counted as maternal deaths, showing deficiencies in field care for high-risk women during this COVID outbreak. So what are the recommendations? To make pregnant women and their relatives knowledgeable on the availability of emergency obstetric care at all hospitals despite restriction due to any situation. All pregnant women and their relatives should be educated on the danger features during the pregnancy and postpartum period and the need for attending to hospital irrespective of the epidemic or curfew situation. Though we can recommend these things are practically not happen during that time. Streamline the availability of specialist care without restrictions and with due safety precautions to all pregnant and postpartum mothers at specialized hospitals. The emphasis should also be focused on shared care in referral and back referral following discharge from hospital and on quality of postpartum care. Update and recirculate guidelines, circulars on the need for the physical presence of each category of health staff in managing maternal cases and to emphasize the strict adherence to the same. As a college, we have done this under the chairmanship of Dr. Mangala Disanayak and Professor Pradeep De Silva. We have developed about 14 guidelines during my tenure in office this year. So we are on the track, and we have developed the guidelines for labor care also, and we have presented that to the Family Health Bureau, and it will be a national paper in time to come. So we are taking actions. We are taking these recommendations very seriously, and as the college would like to help Family Health Bureau and the Ministry of Health to reduce these maternal deaths. Identify gaps in essential logistics at hospital level in caring for pregnant and postpartum women and facilitate provision of them with due priority. Streamline the Red Book strategy in providing targeted field care for the vulnerable women at risk of dying. Then other most important thing is to upgrade mental health literacy in general public with a special focus on pregnancy and postpartum period. So this is the report for the 2022, and I would like to acknowledge the services done by the below mentioned organizations. I would like to acknowledge the MCMM's unit team members. I'm sorry I can't mention the names individually, it will be a long list. Then Director and NPMs of Family Health Bureau, SLCOG, all the past 34 presidents, they have done the tremendous job to improve the maternity care. And out of that, I would like to acknowledge the greatest service done by Dr. Ajitha Vijayasundara. Sir, thank you very much. As a president of the college, I acknowledge what you have done for continuous 10 years. You have helped the college for participating in this review with the Family Health Bureau. And President and the Council really appreciate what you have done in these last 10 years. In addition to that, all the past presidents of the college have been involved with this. Out of that, few past presidents are here. I would like to acknowledge Professor Deepal Veerasekara, sir, thank you very much. And Dr. Kanisha Karunaratne, thank you very much, sir, and Dr. UDP Ratnasiri. Then Dr. Lakshman Seranaka and Dr. Ananda Ranatunga, they have also have done a tremendous service for helping the college as well as all the other past presidents. Then from the college, I will be failing in my duty if I don't thank Dr. Mangala Disanayaka and my council. All they gave me a very good support and they were really encouraged to do this task. Then other professional colleges, reviewers, all the other colleges relevant to maternal deaths, they were really supportive to these desk reviews, national desk reviews. And so presidents and the councils of all the other colleges I would like to acknowledge, and especially Dr. Ramani Pallimulla. She was my colleague at Castle Street Hospital, but she has been there all the time and supporting us. Then the CCPs, MOMCHs and MOHs, MOPHs, then all the PDHs, RDHs and hospital administrators, they were really grateful. And DHs and MOH and Ministry of Health directors and DDHs, and especially Family Health Bureau staff and accountants and office staff and drivers were really helpful. But having said that, we have to think what is the way forward. Always SLCOG was promoting and supportive for confidential inquiries into maternal deaths. So our way forward is going into confidential inquiries into maternal death. I am very happily mention that we have started confidential inquiry into maternal deaths. That is the world accepted way. In this year, as a pilot project covering the districts of Colombo and Matara. So this pilot project we have to nationalize and to make it to reduce the maternal mortality further. The SLCOG bear the opinion that we have to go for the confidential inquiries into maternal death, and for that I appreciate the support given by Dr. Chitramalidi Silla, Dr. Kapila Jayaratta and the Director General of Health Service and Dr. Harendra and all the Family Health Bureau staff as well as the SLCOG, my council, for helping me to make it a reality. So that is the way forward, and this analysis was done on the old format, MDSR. So from the year 2022-23, we hope, we would like to see this as a confidential inquiries into maternal death format. So let me reduce maternal deaths to the single digits in years to come. Thank you very much.
Thank you, Dr. Enroll. It was a wonderful year. Last year, we could do many things together, thanks to the college members and the reviewers. Now it's time to focus on infant mortality. I cordially invite Professor Shaman Rajendrajit to give an introduction, and Dr. Nishani Lucas to present the infant mortality analysis for the year 2017 to 2019. Shaman, over to you.
Good morning, everybody. I think I will give you a small introduction to what we did, and Nishan will present the data. So when I became a consultant in 2005, the first thing I wanted to do, not gastroenterology, but actually to do some work on neonatal. But during that time, there was this series was published by the Lancet group led by Professor Sulfika Bhutta. Why, how, and when neonatal deaths occur. So the title of the paper I still can remember. 4 million neonates die in the world. Why, when, and how? So that was the thing that is stimulated me to work on some of the papers that we did initially. And actually my first published paper was on copying that or looking at that and writing something about same thing in Sri Lanka. We got the data from the Registrar General Office and analyzed this data. So and that was published in 2008 actually. So that was the history. So when the Family Health Bureau advertised that they wanted to do the analysis of infant mortality data from 2017 to 19, so we saw the opportunity as the leading university of the country, the Columbia University. We took that challenge and we applied and we got the bid, and then we formulated a team comprised of Dr. Nishani Lucas, Dr. Prasad Chaturangana, and Dr. Hasita Lianarachi. So we worked with Dr. Kapila Jayaratne and Dr. Chitramal De Silva very closely and got down these piles of papers from all over the country to look at. We had several number of demonstrators, so that we worked on it. And I must say that was a very tough task because extracting data was not the easiest thing to do in a pile of papers and PhDs which are haphazardly written and all that. But somehow we managed to extract those data and give a meaning to that, which Nishani will present to you. So I must say it was a difficult task. Dr. Kapila Jayaratne was not the easiest person to work with at that time, although he was a good friend. And Dr. Manjula Dhanansuri was up to the target because she was pushing us to do this on time, and actually we were able to finally compile the data set and did the analysis. So we will look into that, and I hope there is a very learned audience here, led by some senior consultants and professors. So we can probably be able to give a good meaning to this data set that we generated, and I'm sure this will followed by a very good action plan that will reduce the neonatal mortality rates of this country and bring the global neonatal deaths that I was that stimulated my head to do research on whatever the thing in pediatrics. 4 million neonates die in this world, why, where, and how. That should never happen again. And Nishani, I cordially invite you to present our data set. Thank you.
It's okay.
Very good morning to you all. I think Professor Rajendra just introduced what we were working with. So let me get started. So we actually analyzed the neonatal and infant mortality from 2017 to 2019. So just an introduction that these neonatal and infant death rates are essential indicators of social development, and it reveals the overall health status. And if we look at the world figures, we can see that South Asia is the purple line, quite high up above, just below Africa. And if we look more in detail at South Asia, we see Sri Lanka is the green line right at the bottom, so we are doing pretty well. But can we improve and can we maintain it? So the infant mortality rate from a historical perspective has gone down from the 1950s to the 2020s. But you can see now at the last part where it's below 10, the drop is sort of getting stagnant and it's slow. So in order for us to improve further, we would need to go in for a more in-depth analysis, which sort of prompted this sort of review. Looking at the neonatal mortality, we see a similar picture where it is going down quite well, but our goal for 2030 is 2.2, and we are around 6-ish, 6.5. So again, in order for us to, I think we've done most of the hard work and things have got better, but in order to get better and maintain this, we would need to know what we can do, improve. So looking at the percentage distribution, we can see early neonatal deaths are about 50 to 60%, with about 20% late neonatal and 30% post-neonatal deaths. So when it comes to surveillance of fetal-infant deaths, there are facility-based assessments, that is confidential reports, as well as community-based verbal autopsies. So these are the documents that we had to go through in order to get this data. So the objective for us was to perform a qualitative as well as a quantitative analysis of the data on infant deaths, which was reported to the Family Health Bureau from 2017 to 2019. So we had to describe the quality of the data, review the surveillance system, do a cause-specific analysis, trends, mortality rates, look at the preventability, describe the socio-demographic factors, and formulate evidence-based recommendations to decrease infant deaths. So all the formats that were available at the Family Health Bureau with regard to deaths from 2017 to 2019, which were given to us, were examined. Then there was also a database that was there that was also examined, and we developed a new database, and we looked at all the paper records and graded the data quality. And we also had to triangulate the data sources, because for the same death, there are documents coming from the field as well as the hospital. And Family Health Bureau has a manual system, so it's kind of really hard to sort of put the two together with the resource limitations they have. Then quality checks were carried out to ensure that we are not double reporting the same thing. And each infant death was assigned a cause of death by scrutinizing all the available information. So the forms that were filled, the copies of the diagnosis card, clinic books, each infant death was looked at by a consultant, either a pediatrician or a neonatologist. And we would come up with the cause of death. If we were not sure, we would discuss and sort of classify it. Each infant death was given the ICD-10 WHO classification, and each neonatal death was also coded in addition with the ICD-PM WHO classification. Data was cleaned and analyzed. An in-depth review of formats of reporting deaths were done, and we analyzed this secondary data from the database. Then we also got some other information from the perinatal death database from the Family Health Bureau, but those were just in numbers and were already coded, so there was no way we could check whether the authenticity of that data. So that was taken into the numbers, but it was not taken into the detailed cause of death. What were the deficiencies that we found out? So there was inaccurate assignment of cause of death, cause of death, some of it was entered as cardiorespiratory arrest. I would show you the numbers when we go to results. Only few variables were included, and the existing database that the Family Health Bureau had at that time did not have any information on preventability. Then there was no coding. Then there was no information on the data quality. And the entered data was not in a format that could be analyzed. And we had to re-enter almost all the data. So initially we started off by adding a lot of variables because we were obviously very enthusiastic at looking at a lot of things and how to prevent. But as we got along with it, it became very tedious and we had to cut down and revise it again. And we found out some of the problems that were there in the database. So putting drop-down menus, using a classification for occupation, simple things like that. We were able to sort of clean the database. So data was cleaned and data sets were prepared by 2 reviewers, 1 independent, 1 consultant, and 2 technical experts. So as I mentioned, the cause of death was assigned by a consultant after scrutinizing all the information, and each infant death was assigned only 1 underlying cause of death after performing the root cause analysis. And it was coded according to WHO and ICD-PM. And if there was insufficient information to determine cause of death, it was given as not available. And all changes were discussed with the consultants, technical experts, WHO country office, as well as the national program manager. So I'm sure you already know this. Infant death is the death of a baby between day 0 and day 365. Neonatal death is within the first 28 days. Early neonatal death is within the first 7 days. Late neonatal deaths, day 8 to day 28. Post-neonatal deaths after the neonatal period, but within the infancy. And the age of death was calculated by entering the date of birth and the date of death, where automatically it would calculate, and this was rechecked with what was entered as well. So period of gestation was the last completed week as given in the form, and live births, any mention of movement, respiration, heart rate. So calculation was using these formulas: early neonatal deaths divided by the number of live births times 1,000, and similar for the others as well. So moving on to the more interesting part, results. So the quality of data. So there were 4 formats that was received by the Family Health Bureau, 2 formats from the field and 2 formats from the hospital. So F6 is a field investigation format, which was the thing that we saw the most, and the others were not that much. So if we look at what has happened from 2017 to 2019, only field formats were seen in sort of 70 to 80% of the deaths, whereas where the hospital formats had also come in was only about 20%. Again, there may be issues of triangulation as well, but towards the end we sort of got better with the thing and triangulation got easier, but it was quite challenging. So grading regarding completeness. So although the form was there, was the form useful? Was it filled properly? Was the next question. So about 40% or more of the forms did not have most of the information needed. So we really need to improve the quality of how the forms are filled. The correct identification of the underlying cause of death. So that means looking at the whole forms, all the pages, all the documents, everywhere for words. If we find the cause of death somewhere, we give it as, okay, it is written somewhere. But it was not given in the allocated spot. So correct allocation of cause of death in the field format was around 40%, and in the hospital format was about 30%. Then correct identification of immediate cause of death was around 30-odd%. Then cardiorespiratory arrest or multi-organ failure was given in the field form as a cause of death in around 33 to 28%. In the hospital forms, again from about 8 to 30%. And milk aspiration is being given as the cause of death without any background whatsoever, which appears like sudden infant deaths are being labeled as milk aspiration without an autopsy or anything like that. So infant and neonatal mortality. The country level infant mortality rates were 8.8, 8.3, and 8.8. pretty stagnant. And if we look at provincial-wise, we saw that it was highest in the northern and the northwestern province. District level, Mortality gave high numbers, but we also, when we discussed, we were wondering whether it was because of the low number of people and high number of deaths, followed by Kalutara, Nuwara, Kampaha, Jaffna, and so forth. So the neonatal mortality rates, 6.1, 5.7, and 6.1. And the provincial level neonatal mortality rate, similar pattern with highest numbers from northern and northwestern province, followed by eastern and central provinces. Again, highest district with neonatal mortality rate also appeared as Mortality, followed by Kalutara, Nuwara, Kampaha. So it followed a similar pattern, both neonatal and infant mortality rates. So 84.7%, almost 80 to 90% of the deaths took place in a hospital, whereas NA is where it was not given, where it took place, and the rest of it, there were only very few in the field, and there were some that took place at home. According to the level of institution, most of the deaths happened at either a tertiary level or a secondary level institution. Looking at the time of death, so early neonatal deaths were responsible for about 50% of the infant deaths. Late neonatal deaths were responsible for about 20% of the infant deaths, and post-neonatal deaths for about 30% of the neonatal deaths. So if we compare this with the picture I showed you before, it's pretty similar pattern. Then if we look at the characteristics, parents' characteristics, we compared the characteristics of these deaths with each year with the DHS, and we couldn't see any difference whether they were married or not. With regard to religion, however, we saw a higher number of babies whose moms were either Hindu or Islam, higher number than the DHS. This same pattern was reflected in the ethnicity as well. Again, same thing with paternal religion. And with regard to maternal education, it was similar to what was seen in the DHS, or maybe the secondary level education was a little bit lower. Again, with paternal education, similar pattern was seen, what was seen in the DHS, with what was seen with the babies where the deaths occurred. With regard to maternal occupation, commonest was housewife, but then again, that is the same trend that is seen in our DHS as well. With regard to paternal occupation, we saw high amount of skilled manual workers in the babies who died compared to the DHS, where there were higher amount of elementary occupations, which were lower in the sample population that we saw. With regard to maternal age, so according to the Family Health Bureau data of 2019, it was about 12.9% of the moms who were of advanced maternal age. But if we look at the deaths, you could see that the percentage is slightly higher among the babies who died. So consanguinity was present in about 4.7 to 5.6%. Previous child deaths, again similar, around 5%. And most of the mothers, either this was the first child or the second child. Infant characteristic, there was no gender predominance, sex distribution was similar. Ethnicity, again, was higher among the babies who died compared to our population characteristics in the DHS 2016 for both Tamil and Muslim ethnicity, similar to Hindu and Islam. So gestation of infant deaths, most were term deaths, but you could also see that less than 28 weekers and 28 to 31 weekers, these are extreme preterm and very preterm babies, are responsible for about 30% of the deaths. So early neonatal deaths, again, less than 20, with the more preterm they are, they contribute more to the early neonatal deaths and the late neonatal deaths. And for other reasons, term babies is the light blue column, 37 to 40 weeks, contribute more to the post-neonatal deaths. With regard to the birth weight, again, because of the higher contribution and the higher population of the bigger babies, 40% are the normal birth weight babies, but there is 19% who are less than 1,000, the extreme low birth weight, and 1,000 to 1,500, the very low birth weight. So these are most of the time the preterm population which are actually responsible for a large number of deaths. APGAR score was not available in most of the forms. 70% it was not available. And it was only around 5% that it was less than 7. Resuscitation at birth, again, was needed in about 35%, 20 to 30%, and not needed in a similar number. And again, it was not available in 30 to 40%. Exclusive breastfeeding was seen in around 23 to 28%. It was not recorded or not relevant, actually. Not relevant is NR in a few babies if the baby died soon after birth, and it was not recorded in almost 30 to 40% of the forms. So pregnancy characteristics were, we could not find a distinct pattern with pregnancy characteristics along with our deaths. Neither did we find a distinct pattern with parity or the type of pregnancy. So most mothers, 62.4% of the mothers, did not have any maternal disease, those who had infant deaths. So cause of death analysis according to the ICD-10. So when we assimilate all deaths from 2017 to 2019, 39% for the leading cause of death was due to congenital anomalies, and this was followed by prematurity, and then it was followed by meconium aspiration along with persistent pulmonary hypertension, as well as other causes. In hypoxic ischemic encephalopathy accounted for 4.6% of the causes. So you can see that infection is not a whole leading cause anymore. And just a word of caution when we are reporting infection, because infection may be the immediate cause of death in many babies, but we have to look for the root cause. Is it because the baby was preterm? Is it because the baby was congenital anomaly? If it was that, it would go under the congenital anomaly label. So timing of death versus the underlying cause of death. Early neonatal deaths were mostly due to congenital abnormalities and preterm. Again, you can see late neonatal deaths also due to the same reasons. But when it comes to post-neonatal deaths, others also starts playing a role in addition to congenital abnormalities and prematurity. So what are these congenital abnormalities we are talking about? The commonest congenital abnormalities that cause death were circulatory abnormalities. We'll go into detail on what other is. Other abnormalities accounted for 19.6%. 13% were nervous system abnormalities, 11.8% were musculoskeletal abnormalities, followed by chromosomal abnormalities. So circulatory system is unspecified in 41%. This means it's just written congenital heart disease. That's all. So there's nothing more we can really get out of that. From what was given, hypoplastic left heart accounted for most, 9.6%. Other meant these are mixed anomalies which are not confined to one particular system. So sometimes it is written multiple congenital anomalies or grossly dysmorphic baby. So those things would go under other, where many systems were affected. So among musculoskeletal system, congenital diaphragmatic hernia was the commonest, followed by exomphalos, thanatophoric dwarfism, and June's disease. Among genitourinary system, renal agenesis was the commonest, followed by polycystic kidney disease. Among nervous system abnormalities, anencephaly was accounted for 35% of the nervous system abnormalities, followed by hydrocephalus, spina bifida, and encephalocele. Amongst chromosomal abnormalities, Down syndrome accounted for 51%, whereas Edward and Patov syndrome accounted for 42% and 4% respectively. So among respiratory system, lung hypoplasia was the most common abnormality noted. Prematurity. Among the deaths that were caused due to prematurity, extreme preterms accounted for more than half. And so that is just to say that this is an emerging problem, and if we look at the neonatal mortality rates, actually prematurity is superseding congenital abnormalities for neonatal mortality. Then moving on to hypoxic ischemic encephalopathy. So hypoxic ischemic encephalopathy with supporting evidence was taken as when there is at least an ABGA score showing the ABGA is low, resuscitation details, what was done, any clinical picture, what happened to the baby, investigation results, and absence of major congenital malformations and prematurity. But we also took others that were written as birth asphyxia or just hypoxic ischemic encephalopathy, where there was no ABGA score, no resuscitation details, and it did not really allow us to verify whether these were correctly named or not. Meconium aspiration syndrome and persistent pulmonary hypertension were taken together because the commonest reason for PPHN is meconium aspiration syndrome. So if it was given as persistent fetal circulation, it was included. Any problem due to meconium aspiration syndrome was included. And it should not have any other root cause or underlying diagnosis. For example, if there's meconium aspiration and group B streptococcus pneumonia, we should take the group B streptococcus pneumonia as the root cause, because that is the reason why the hypoxia or the meconium or whatever has happened. Then coming on to infection as the underlying cause. So the infection should be the primary cause. It should not be secondary to a congenital infection. It should not be secondary to prematurity or some other issue. So sepsis, just sepsis without any other information was the commonest thing. And that accounted for about 27%. This was followed by congenital pneumonia, bacterial sepsis, necrotizing enterocolitis, and so on and so forth. So I would just encourage doctors to write a little bit more rather than writing sepsis as a definition. It's very loosely used and very haphazardly used. It may be inborn errors of metabolism without a blood culture, without a CRP that is high. We can't just label any neonate that is sick as sepsis. We found a lot like this, which we delabeled actually, because when we went through everything and if it was wrong, we took it off. So intrauterine growth restriction, where it should state growth restriction or small for gestational age, which is not secondary to either congenital anomalies or congenital infection. Then respiratory tract infection and acute gastroenteritis we analyzed separately. So bacterial pneumonia was the commonest diagnosis, followed by bronchopneumonia, followed by unspecified respiratory tract infection. Acute gastroenteritis with supportive evidence were available. If they have mentioned anything about dehydration or if the AGE was not secondary to another underlying cause, it was taken as the main cause. And if the only thing that was written in the form was AGE, then we took it as AGE as well. Moving on to sudden infant deaths. So there were 45, 43, and 21 sudden infant deaths from 2017 to 2019. So this is either this label was given dead when detected by the parent or the hospital staff without any obvious cause of death. So most of these babies have died at home, and postmortem was done in about 51 to 57%. About 9 to 26% were preterm, 29 to 48% were low birth weight, 55% were male. Again, the predominant amount of the 50 to 66% was Sinhala, 19 to 24% Tamil, and 10 to 23% Muslim. And they were mainly from Puttalam, Gampaha, and Kurunagala districts, and in different years. Again, the maternal age more than 35 years got highlighted again. The percentage was more in this group. And fathers with elementary occupation were higher than seen in the whole group as well as the national number. And these people had lower income level as well. So if there is no other reason and we don't know why the baby died and the baby was dead on admission, we should not really label it as milk aspiration. There will be milk anyway. So it's important to do a postmortem and try to identify what has happened. So because there are a lot of misdiagnoses like that. Then deaths due to accidental, intentional, or unspecified injury. Infanticide was the commonest injury which was seen. Intentional injury was like the, accidental injury, the commonest accidental injury was the road traffic accident, the commonest intentional injury was infanticide, and the commonest unspecified injury was aspiration of food. Injury-related deaths. Average age was 4 to 6 months. Death on admission in 49 to 77%. Majority were male. Again, commonest in Gampaha in 2019 and highest number in Kurunegala. Again, these two districts were highlighted. Maternal age more than 35 years in 5 to 23% and elementary occupation and lower income level. So I guess what we learned from that is that we have to be more careful and more supervision is needed. The poorer the socioeconomic status along with elderly mother and other risk factors. What are these other causes in the underlying cause of death? So these accounted for neurological disorders most commonly, followed by metabolic disorders, cardiac, renal malignancy, blood, intestinal obstruction, hydrops cirrhosis, post-surgical complications, immunization reactions, and anaphylaxis reactions as well. So underlying cause for early neonatal death according to the ICD-PM classification shows us a similar thing, where N1 is congenital abnormalities, and N9 you can see very high levels of low birth weight and prematurity. N4 are the complications of intrapartum events. So maternal conditions related to early neonatal deaths, most of the time, as I showed earlier, they were mothers who did not have any other problem other than N9, which is the prematurity group where the babies may have been delivered due to maternal issues. With regard to immediate cause of death, sepsis was the commonest immediate cause of death, which accounted for about 9.5%, which was followed by surfactant deficiency, pulmonary hemorrhage, lung hypoplasia, and many more. So milk aspiration also you can see here, this was taken when there was a post-mortem or there was actually someone had visualized the thing happening and it was documented well. Milk aspiration could be taken as immediate cause of death, especially in a child with a neurological problem or in a child who is preterm, but not in a well baby otherwise. District-wise comparison with underlying cause of death. We can see prematurity is pretty high in some of the districts. It may be, some may be because babies are referred, but the others, I'm not really sure of the reason. Matale, Matra, Monaragala, Mulati, we can see all the latter part of the district, the amount of deaths due to prematurity is pretty high. So maybe the facilities are not great. We might have to look into why there is a high level of deaths in that group. And then some districts we can see congenital anomalies are higher than others. For example, Hambantota, Ampara, Badulla, Colombo. I mean, it may be that babies are being referred into these places, but I think it's important for us to go a little bit further into it. See, and then in some districts like Mana, we can see the deaths due to meconium aspiration are high. So is there a problem with resuscitation? Is there a problem with the obstetrics? There are a lot of questions that need to be answered in looking at this as to why there is a discrepancy between deaths in different districts. So relationship between the cause of death and parent characteristics, again sex distribution did not play a significant role. Ethnicity-wise, we saw a higher number of deaths in Tamil and Muslim ethnicities compared to the national distribution. The place of death, so the orange color is hospital, most of the deaths occurred in the hospital. Maternal education was secondary or higher in most of the in almost all of the deaths. So NA is where the information was not available. Similar pattern with paternal education. Again, religion showed the same thing. where there was no significant difference between the cause of death and the religion of the parent. Same pattern with maternal religion, and with period of gestation versus the underlying cause of death. We could see that preterm babies, obviously prematurity would be due to all the preterm deaths, but they are also more prone to die due to injury. They are more prone to be abused, more prone to have injuries done to them. So again, it's something to think about and ensure that these children are safe at home after discharge. Maternal religion, we couldn't find a specific pattern with regard to the cause of death as such. Again, paternal religion, also there is no major pattern there other than the minority ethnic groups, the amount of acute gastroenteritis and the respiratory tract infection is a little higher than the rest. Have I done? Sorry. Birth weight versus the underlying cause of death. Again, prematurity accounts for most of the babies who are less than 1,000 grams. And again, you can see injury is quite common in these babies, but most of it is yellow, which is the normal birth weight baby. Again, exclusive breastfeeding, yes, is blue color, so you can see it has not happened very well for preterm babies or the growth restricted babies or the babies with hypoxic ischemic encephalopathy. So those are areas we need to focus on. So although this message is being given, maybe it is not being transmitted well enough. So what about the parent satisfaction? 72% of the parents were satisfied. Only 6% were not satisfied. So most of the time the data was not there. The gray color is when the data is not there. 22% were satisfied about home visits. So overall care was given as average to excellent by whatever data we had, but most of the data was missing. Again, parent satisfaction on infant care received, many parents were satisfied about it. With regard to the delays, so different delays were detected in a few of the deaths, which was around 1%, but delay in seeking care was seen in 6%, delay in reaching care was seen in 2%, and delay in the field was seen in 3%. Again, delay in clinical management was seen in 2%, but the rest due to lack of staff, lack of facilities, and administration was only 1%. So with regard to delay in seeking care, 61% of the acute gastroenteritis patients, there was a delay in seeking care, again with infections, other illnesses, respiratory tract infections, sudden infant deaths, injuries, so all these areas there was significantly higher amount where there was a delay in seeking care. Delay in reaching care, again acute gastroenteritis, sudden infant deaths, injuries, there was an issue along with respiratory tract infections. Delay in field care, again had the same pattern, as well as the delay in pre-admission care. Delay in clinical management, again acute gastroenteritis strikes out along with respiratory tract infection. So information from both, in conclusion, information from both hospital and field were available only for about 20%. So we suggest to initiate zero reporting and make it mandatory for every hospital to send a monthly return, irrespective whether they have infant deaths or not. And we also suggest to collect data electronically to increase the data capturing, where each end user should have access to his or her hospital or MOH data, dedicated email addresses, prompt feedback, and to encourage every institution to calculate their infant and neonatal mortality rate and present it at the monthly perinatal meeting. Then to give the responsibility of reporting it to the head of the institution along with the respective pediatrician or the neonatologist. And the focal point should flag the institutions that are not sending the returns and address these issues with the institution heads. and director would be accountable for reporting the death within 24 hours. We can maybe make it 48, I don't know. And so that there is some form of responsibility and making sure that the whole pathway works. And use infant and neonatal mortality as a quality indicator for each hospital. Then data regarding the early neonatal deaths is going to the perinatal database and it's not coming into infant deaths, and that is again a problem, and that makes it look like the hospitals are not really reporting. So again, better triangulation and getting it together would be better. So early neonatal deaths should be reported to both perinatal and infant mortality systems, preferably in electronic way, and to suggest to take a copy of it and collate it with the early neonatal deaths. So collating the records related to the same death is technically difficult, time consuming and prone to error, as there is no unique identifier, because you have to look at different sheets of paper and decide whether this is the same death or not. So we recommend to have a unique identifier based on either the number of the birth certificate or something like that, so that both hospital and field can independently give each death the same unique number to make triangulation easier, more efficient, and more accurate. Many variables are repeated in both hospital and field form, creating a huge burden on data entry. So we suggest to identify only the essential variables and avoid repetition between the hospital and field form, because it's neither field in either one. Different types of formats were used to enter data, resulting in some variables being left out. I think with time, the type of format that was used has changed. So some forms, the same field format form had different variables, some of them didn't have it, so it's important to make sure the updated format is used by everyone. To improve the quality of data, have an online format which does not allow to proceed without completing all the sections. Increase awareness among the end users with regard to how to fill this and accurately determine the cause of death and its preventability. Root cause analysis should be used for assigning the underlying cause of death, and use arrows with a flow chart to facilitate a more accurate assigning of cause of death, starting from the underlying cause and ending with the immediate cause to minimize the errors. So increase awareness on the ICD-10 WHO coding system, which is available online, as well as the ICD-PM system for the end user, to understand how a death should be reported, and to provide a link in the infant mortality database to ICD-10, ICD-PM, to facilitate a more accurate allocation, because finding these things are actually difficult and time consuming for the person who's actually in the ward and filling these forms as well. So if we do make this online one day, someday, it's important to have this classification close by. Inability to verify the cause of death with details. We encourage to help to support in documents. The format of the perinatal death, again, to be changed to a flow diagram so that the root cause analysis can be done. Encourage postmortem in all cases thought to be milk aspiration in the absence of a definite risk factor. Sudden infant deaths that occurred at home and on admission were not investigated adequately as per infant death format. So in previously healthy children, sudden deaths should undergo a post-mortem examination with histology and thorough investigation in the absence of a definitive diagnosis. And it's important to escalate services to protect the vulnerable groups. So extreme preterm babies, ensure in utero transfer, delivery at level 3 or more with a hospital with a neonatologist, ensure exclusive breastfeeding, antenatal optimization, optimize infection control practices, and all these things. And we had to make sure that they have good home care after discharge as well. Minority ethnicities, we have to ensure equity of care, and that health messages are given to all ethnicities effectively in all languages, because we saw that deaths are higher in the minority ethnicities, and ensure awareness among the minority ethnicities in the language of their choice, and even about things like acute gastroenteritis, home management, oral rehydration solution, and so forth. So infection was the fourth most common underlying cause, and high percentage of deaths due to infection was seen in Batticaloa, Mannar, Matale, and Kurunegala. So I would think we have now gone into detail about the cause of death, and we have district-wise analysis. We can even have MOH-wise analysis if you need to. I think we should sort of, talk to them, or, get their, maybe things are lacking, maybe there are issues, but it needs to be addressed because these are easily preventable deaths. Again, interpartum prophylaxis on group B, and going through all these things and things that can be supported. Good infection control practices, monitoring babies for at least 48 hours when there are risk factors, and all babies with congenital pneumonia or sepsis should be managed at least in a level 2 unit. Again, respiratory infection related deaths, infants less than 1 year with features of respiratory distress should not be managed as outpatient, and they should be managed as inpatient in the nearest regional center with a pediatrician. And early recognition and transfer to such a center would optimize the outcome. Because again, deaths due to respiratory infection and acute gastroenteritis is not at all acceptable in this age and day. So it's very important that we go into detail why these happened at all. Acute gastroenteritis, we have to make sure that the treatment protocols are up to date, and everybody knows how to handle dehydration, and the PHM MOH should ensure that caregivers are aware about it as well. Hypoxic ischemic encephalopathy, so prevention by optimal monitoring of the fetal well-being, and provision of timely therapeutic hypothermia within 6 hours of birth. So the important thing is to prevent it, but by any chance if it happens, we do have cooling facilities in the country now. It's very important to know where they are and to timely transfer within that 6 hours. Again, meconium aspiration syndrome, the highest number of deaths were seen in Mana and Kurunegala, so it should be looked into as to why some districts are having a lot of deaths due to meconium aspiration syndrome. So it's important to ensure that meconium stain LICO is recognized by the obstetric team, fetal monitoring is commenced, and the pediatric team is informed, and necessary steps are taken. And all the meconium stain LICO patients should be informed to the pediatric team, and it's important and vital that a member of the pediatric team is there when the baby is being delivered to ensure that resuscitation is done if needed. So this is all about how to optimize care for a baby with meconium aspiration syndrome. Deaths due to accidental and intentional injury. Mothers need to be routinely screened for postpartum psychiatric conditions, because we see this even in our day-to-day clinical work. And father should also be screened prior to discharging the baby home, because there were babies who were stabbed, bashed, drowned, and multiple knife things. So the only way would be to have some sort of screening at some level. Antenatal and postnatal education should also include healthy parenting, what to expect when the baby is crying and all that, and also how to get help and how to prevent accidental injuries like drowning, poisoning, aspiration. Sudden infant deaths should be investigated with a mandatory postmortem. Milk aspiration should not be given as a cause of death unless it is the only abnormality detected at the postmortem. Infant sleeping arrangements should be discussed prior to discharge, because co-sleeping is very common in our country. It's okay, we can have co-sleeping, but we must make sure that the mom and the dad are not on street drugs, not on alcohol, not smoking, and are not on sedatives. And they know about the risk, about what they do is affecting the child. Using safe transport, including car seats. And investigate why certain districts had a higher percentage of deaths from congenital abnormalities. Then again see whether folic acid was taken or not and why not, and instigate necessary action. And again, preventing things like maternal diabetes, consanguinities, and other maternal factors that increase the risk of abnormalities. And also increasing awareness that maternal age more than 35 years seems to be increasing the likelihood of infant deaths. And ensure exclusive breastfeeding is practiced for all infants by maintaining audits, and investigate why they were not breastfed. and strengthen the field care. Then again, age-appropriate immunization the information was not there in some and it was not done in some. So again, to make sure that it happens. Thank you.
Thank you, Nishani. We will be skipping the next session and going into the learning from maternal deaths. So I want to acknowledge the previous analysis on infant mortality that was supported by World Health Organization and the Ministry of Health coordinated this activity, and the Professor Shaman Rajendrajit and team did the work. So going on to the learning from maternal deaths, this was also supported by World Health Organization, and we worked, Family Health Bureau and World Health Organization in analyzing these deaths and translating it for meaningful data to utilize at both national and peripheral level. So to start with the session, I would like to invite Dr. Manjula Dhanansurya, National Professional Officer of WHO, to describe the analysis model.
Thank you. Distinguished invitees in the head table and ladies and gentlemen, I will briefly touch upon the WHO support to the Ministry of Health in few in-depth evaluations on maternal deaths and MDSR processes in Sri Lanka. As you know, core functions of the WHO, we always prefer on providing technical support to the member states, as well as on finding evidence globally as well as locally for informed policy decisions. So as per our core functions, we supported 3 in-depth evaluations on maternal death. The first one was on review maternal deaths and maternal near misses between the years of 2014 and 2018. We did it in 2019 and 2020, but we couldn't disseminate because of the COVID situation. So as my previous speakers highlighted, Ministry of Health wanted to review the stagnant maternal mortality rate and near-miss deaths to identify strategies to reduce maternal mortality rate further to reach the SDG targets. So our objective was to analyze maternal deaths, scrutinizing hospital records and all the databases, and we performed a protocol-based audit with regard to, with the objective of identifying the underlying cause and suggest recommendations. And we focused on 6 main areas with the support of Professor Hemantha Senanayaka, and he will be sharing the key findings and the conclusions and the proposed recommendations in few minutes. The second in-depth evaluation was, as highlighted earlier, we wanted to evaluate maternal suicides reported between 2003 to 2019. And again, to describe the trends and factors associated, and also to make recommendations on enhancing maternal mental health services, which has been highlighted by my previous speakers. So we did quantitative and qualitative data analysis, and Professor Tilini Rajapaksa will present you the key findings and the recommendations. The third evaluation was the post-mortem process, because Ministry of Health has introduced this post-mortem about 10 years back. Although we have a very good coverage, the ministry thought it is high time to do a kind of process evaluation to enhance the quality. So we did evaluation on the post-mortem records reported from 2011 to 2020. And again, it was a quantitative and qualitative analysis, which include quality of cause of death analysis, as well as documentation process, whether to what extent the post-mortem process was in compliance with the guidelines, and also overall quality. In addition, we supported a few other assessments, including 2019, we did a situation analysis of level of MPDSR implementation, on also pilot testing the global MPDSR operational materials in Sri Lanka. So as a country, we were supporting the global goods. In 2020, again, we did a rapid assessment on MPDSR system as a part of regional exercise. And in 2022, we did a country case study on MDSR, especially focusing on the response. We will be incorporating this in the upcoming Global Maternal Health Report. Thank you very much.
Thank you, Dr. Dhanan Surya. The next presenter is Professor Hemantha Senanayaka. So he'll be presenting on the qualitative analysis of maternal deaths 2014 to 2018. Over to you, sir.
So thanks, Kapila, for this opportunity. I want to thank, acknowledge the people, the dignitaries on the head table. I want to thank the WHO for asking me to do this very important analysis. And I've just basically come here from the airport because I was in New Delhi attending a meeting there, and the title of the meeting was Going for Zero in Preventable Maternal Mortality. And they got me down saying they want to learn from Sri Lanka, but really when I sat there, I thought there is a lot for us to learn from there as well. Because they are very serious about reducing maternal mortality. They are bringing one intervention after the other. They are identifying gaps, and they are very, very responsive in their system. They are very passionate about it. So I think there is a lot to be learned from there. That main thing is they are very serious about it. So to get on with it. So this is the story of maternal deaths. Really, the house at the bottom, at the back, will never be completed because the father can't go to work. The grandmother has to look after the children. The children will never reach their potential. That's our business. This is why we are here. We want to prevent maternal deaths. It's a noble fight. So the background is that we have a superb system. I mean, these are unbelievable figures, right? Let's take this, the field midwives bring 93.6% of our mothers who are pregnant into the system before they complete 12 weeks. And what a great opportunity that is. And my question is, are we making the most of it? Right. So we know our system is, we have a field system and the institutional system. And really in Delhi, they were asking me all about the field system, really, because they are so impressed with that. And they're asking me, why is it that you have a high cesarean section when they have such a good field system? So the main thing I think for the success of the field system is that they have KPIs and it's being monitored from the midwife right up to the RDHS level. So it's data driven to a good extent. But in the institutional, we are consultant-led like me, and however, we have no KPIs, and then also the policies can vary even within a hospital. Say if you have a woman going past the date, one within 25 yards, there'll be two different policies. So is that a good thing? So we know the story of our maternal deaths, and it's really come down very nicely till about 2010. From there, we've been stagnant, about 32. But fortunately, in the last 2 years, it's crossed 30 and come down below 30. We had this unfortunate dengue epidemic in 2017 that pushed the maternal mortality rate to 39.3. Our SDG goal is 20 by the year 2030. I think it's eminently achievable if we are proactive and we are working hard on it. A look at the direct versus indirect causes of maternal deaths. If I draw a line here at 50%, we have almost 50-50, generally speaking, on preventable, direct versus indirect causes. So really, this is the important thing. In 2016, 2018, and 2020, the main cause was obstetric hemorrhage. We need to do something about it. Also, is that acceptable in a system where 99.9% of women deliver in an institution with skilled birth attendants? Where are we going wrong? So this is how I did the data. Looked at every possible way in the records that are available in the Family Health Bureau. the H677, and then also in the near misses as well, that the reporting was not wonderful in that. So I compared the care standards with the available guidelines and circulars. So I have analyzed in detail 286 maternal deaths. So there is a lot of data. So in a lot of these things, I'm deliberately skipping the demographics because in the interest of time, I have only half an hour. So in obstetric hemorrhage, this is generally considered a very preventable cause. And I think this is something we need to, it's kind of a low-hanging fruit. Generally, globally, it's accepted like that. So here is the breakdown. And the vast majority of the women who die at delivery. So that is where we need to focus our attention on. But however, we need to concede that almost a quarter of these women who die of hemorrhage, for various reasons, will not book with the system. And some of these are within marriage. So we need to look into that, but the thing is, if they are not in the system, we can't do anything about it. And this also highlights something we have been talking about for some time. I think we need to give universal family planning advice for anybody who is above a certain age or who is left school or whatever. We need to set that thing. And I think irrespective of the marital status, irrespective of the eligible register. So antepartum is quite interesting actually. You have a uterine scar, and these are the antepartum ruptures, spontaneous. There was one woman who was assaulted by the husband that resulted in a rupture, but I have left her out of this. So when you have a cesarean section, there is a chance that the scar might rupture. We'll go into details later. So during delivery, so 9 of the women were self-deliveries. During surgery for placenta accreta sequence, that is a thing that really frightens us. You can have torrential hemorrhage. Unless you are really prepared, the woman could die on the table. So we've had 9 women dying due to damage to blood vessels at cesarean section, and then for the obstetricians, I can say 3 of these had damage to the inferior epigastric vessels. I don't know how that happens really. And then also, importantly, 4 cases of intrapartum rupture of the uterus. So here are the women, details of the women who died at cesarean section for a placenta accreta sequence. 3 of these were done by an SHO, and I really think in a real placenta accreta, that woman has a dog's chance of surviving in that situation. A lot of these were done via transverse incisions, and some of us who would have been doing these for some time would use a midline incision for these. So the unfortunate thing is the scans showed that the placenta was low and anterior, but it was not recognized as being a possible accreta. But unfortunately, there was one here, this woman, who had this kind of report. I don't know how this happened. It was done by an SHO. That's not acceptable. We look at cesarean sections. We mustn't forget that cesarean sections in the short term as well as the long term contribute to maternal mortality. So here's 11 women who ruptured the scars, but I want you to notice that these ruptures happened, quite a few of them, remote from term. We are familiar with believing that cesarean section scars rupture during labor, but here this is remote from labor. So it's very important for us to instruct women who have had a cesarean section to come into the hospital early if they get pain during a subsequent pregnancy. So at the surgery for placenta, we talked about it, and also bleeding triggered at cesarean section. I am not including the women who had a true postpartum hemorrhage after a straightforward cesarean, because we know cesarean increases the chance of even a postpartum hemorrhage. So I haven't taken them. So really their contribution is almost 40%. We mustn't ignore that. So our cesarean section rates have been rising year on year, and it's 43.1%, which is very high. And when we look at it, it's a 56.7% rise from 2010. That's a phenomenal rise. And this is area-wise, RDHS area-wise. We have 5 hospitals, 5 regions which are going above 49%. So I think the SLCOG and the ministry needs to take a look at this and maybe go and see these in these hospitals as to why this is happening. What are their issues? So I'm just going to talk, because in my report I have included a lot of case scenarios to as kind of learning examples. So here's a 41-year-old woman who delivered 9 days before, who was transferred to hospital in the eastern province, and at the time of admission she was gasping for breath. And actually the VOG and the consultant anesthetist came to the admissions unit and attended to this woman. She was taken to the theater immediately, and evacuation of the uterus was done, blood was transfused. So she survived that episode, but she later kept going downhill and died. We hear, there are other stories like that as well. There was one woman that I reviewed. The VOG, I think from Nuwara went down to Dikkoya, drove down to Dikkoya to look after, to help his colleague who was looking after a woman who was too unstable for transfer. So we have heroic stories like that as well. But we have the other side as well. Here's a good example. So this woman has had 3 past cesareans. I think she had only girls, and she wants to try for a boy or something like that. Anyway, she had pain for 1 day and went to hospital. She was 17 weeks gestation. The admissions officer, this is a teaching hospital, admissions officer admits her to the casualty ward because she didn't look too good. When she arrives there, the nursing officer says, no, you have been attending the clinics in another place, you have to be admitted to that place. So she is sent back to the admissions place, where she is found to be in cardiac arrest. So resuscitation measures failed. So accountability. Can we go forward without accountability? I want you to think about that. Postmortem showed a ruptured uterus at 17 weeks. Scenario 3. So a 33-year-old gravida 4 para 3, one past cesarean section, who had an elective section by a SHO at term. The patient was received immediately afterwards, and half an hour later, she is sent to the ward. That's pretty quick to be transferred to the ward from the recovery area. And then 30 minutes later, the HO is informed that she is bleeding. The HO comes and sees her at 4:40 p.m. and then starts the usual treatment. But 1 hour later, the bleeding is continuing, the heart rate is going up, and the blood pressure is 90/60 now. 6 p.m. She's seen by the SHO, the bleeding was continuing, heart rate has gone up further, and the blood pressure is remaining, because I just wanted to remind you that unless you lose a real 2 liters of blood, the blood pressure usually doesn't come down. So this is an example of that probably. So 6:25 p.m., bleeding was continuing, heart rate, and then they were instructed to give another unit of blood and blood products and take her to the theater. But basically the woman collapses, dies on the table during a hysterectomy. So I just want to propose to the Family Health Bureau and the College of Obstetricians to popularize the shock index, which is a very simple measure to know the volume deficit, because all this is about volume deficit. So basically, if you have a heart rate, if the shock index is 0.9, it's reassuring. If it is 1 or above, basically it's quite a simple thing to say. If you take the systolic blood pressure and the heart rate is above that, more than, say, systolic blood pressure is 90, heart rate is 110, that's not right. So it's a very simple thing. We don't need to be calculating. If we remember that, we can save a lot of lives. here's an example of where that would have been useful, right? This woman who has had past 2 sections is transferred to a general hospital at 35 weeks with abdominal pains. Seen by the HO 15 minutes later, noted to be drowsy. And again, somebody becomes drowsy when there is the cerebral perfusion is not enough. The woman has lost a lot of blood. So the SHO was doing a cesarean, advised to give a fluid bolus. SHO comes and sees she's still drowsy. By now, the heart rate is 130. The blood pressure is 80/60. It's dropping. So the deficit is increasing. So basically, the MO anesthesia gives the spinal anesthetic. He is a volume depleted woman who is given a spinal anesthetic, and with the vasodilatation that happens with that, the woman collapses, and then there is pandemonium, and she could not be saved. I want to highlight the use of this aspect, the intrapartum rupture of the uterus, which is a reflection of the degree, the quality of monitoring. So if you take these women, if you take the first one, if you take the first one, the amniotomy was done at 5 centimeters. The woman is in active labor, and the oxytocin is started straight away after that. The second one, the woman is contracting. It started because it's slow labor, started at full dilatation. So in the third one, it's the 5th para, grand multipara. We are starting an oxytocin, and we know it's a dangerous thing. I need to look at my time. Okay, I have time. Right. So this practice of starting the oxytocin infusion immediately after an amniotomy, ARM, is a dangerous thing. Right? I'm going to expand on this. Because just the amniotomy will increase the contractions. And then on top of that, we are going and giving oxytocin, and you're really giving too much contractions. I'll show you more these things, right? So out of the 20 women who died of hemorrhage after being in labor, 9 was started immediately after the amniotomy. 6 of them were multigravida. So if you just did an amniotomy and just left her alone, she would have delivered normally. We don't need to do this. I am just wondering whether is it this 8-4 obstetrics that's causing all this. We need to take a look at it as a system. So in our guideline, we say give it 2 hours before we start the syntocinon. I think the practice in Sri Lanka, just like reflexly, people are doing this. So there is another frightening condition by the name of amniotic fluid embolism, and giving oxytocin like this has an impact on that. Let's take a look at amniotic fluid embolism. So a lot of these people had induced labors, and then if you take those women, a lot of them had the oxytocin and having had the prostaglandin as well. So almost 2/3 fell into that category. And 9 were already having contractions while the oxytocin was starting. So really you're asking for trouble. And 7 of them were actually multigravid women. That has not come through here. So here's a good example. The lower, for those people who are not clinicians, the lower one shows the contractions. You can see it's very frequent contractions, over 10 contractions in 10 minutes. And this is actually a woman who had an induction of labor, and the ARM was done at, I think, 6 centimeters. Say oxytocin started immediately afterwards, and this is the CTG 1 hour before the manifestation of amniotic fluid embolism. So it's really too much contractions causing trouble. We mustn't forget, this is from 2011, the WHO guideline on the induction of labor. We are recognized as having one of the highest induction of labor rates in the world. So, I have no reason to believe that has changed in these 10 years. Look at maternal near misses reports. So we identified 56 cases. 4 of them were due to ectopic pregnancies, but out of the remaining 54, 42 had a hysterectomy, because in the reporting criteria, hysterectomy is clearly mentioned. And these included planned hysterectomies for placenta accreta. And then if you take the remaining 31, only 5 had a balloon tamponade. Balloon tamponade is a method of inserting a balloon in the uterus, blowing it up, and blowing it up and creating pressure on the uterine wall to stop bleeding. It's effective 70% of the time. So really speaking, I think anybody who is doing obstetrics, anybody who is providing maternity care should be familiar with inserting a balloon tamponade. The Ministry of Health is providing us, I don't know whether it's still happening, it's providing us with the state-of-the-art and the very expensive Bakri balloon. It's quite expensive, so we have no excuse not to do that, really. Otherwise, we can do what is called a condom catheter. That's also quite simple. So these are my recommendations from going through this. So we talked about the importance of the placenta accreta, telling women, we have to tell the midwives to tell women who have had a cesarean, if you have a lot of pain, it could be your scar is rupturing, go to hospital without delay. Women with suspected or diagnosed placenta accreta, I'm glad to see Dr. Ratnasiri here, and we started doing these cases, accepting these cases. From far away, they come and sit in the wards for weeks. They go back alive. It's much better than going in a coffin, having gone to a hospital close by. So I think there should be a mechanism to recognize units that can deal with that. I think we need to have at least a college, and we must not forget the contribution of cesarean sections to maternal mortality. So that's another reason to bring down the cesarean section rates. And then oxytocin is a dangerous drug. We must treat it like that. Let's look at hypertensive disorders. These are the causes: pulmonary edema, HELP syndrome. We don't think of pulmonary edema in severe preeclampsia, but it does happen. Women have died of it. The numbering is wrong. Just look at this. This is a good example to show what's happening. So woman is going to, she has gone to the DH, and then blood pressure was high, sent to a teaching hospital. She was observed for 1 day. Because the blood pressure came down, she was told, come back in 2 weeks. Really, ideal would have been to say, go to your doctor or midwife and get your blood pressure checked before that. So she is admitted again to the DH again, this time with upper abdominal pain, and then she's treated as having gastritis, esophageal reflux disease, and the allodrox and all the rest of it. But no evaluation was made of the severity of the hypertension. She develops a seizure and is transferred back to the teaching hospital. By the time she goes there, the blood pressure is going through the roof, and then she was unconscious. And the admitting officer found out to be fully dilated, and a bolus dose of magnesium sulfate and labetalol, 100 milligrams IV is given. That's a high dose. We use that dose in hypertensive women, but that's reserved for women who are resistant to lower doses. So 100 straight away, and a stillborn infant was delivered in the ETU itself. I think that way it's commendable. A lot of the things were done in the ETU as well, without delaying. And I think in this kind of situation, particularly the systolic blood pressure is high, systolic hypertension, you have to be aggressive and really hit it hard and without delay. So she was given 3 units of uncross-matched O-negative blood. She kept going down, she died, but the post-mortem actually showed this thing. And this is a very common scenario. So just to remind ourselves that you need to assess these women at least on admission, and I would recommend that we need to have a kind of a minimum standard on admission to undergo all these tests. None of the women who died of hypertensive disease had a comprehensive evaluation at the time of admission to hospital. And I think these would have told us that things are not good. So I want to highlight in this the importance of the systolic blood pressure. If you just look at the middle column, look at the blood pressures, they're very high. So in these ones, you need to act very fast without delay. So the treatment, I think we need to consider protocols where we can initiate the treatment in the admission unit as well, rather than putting her on a trolley and sending her to a ward. So, like I said, clinical and biochemical evaluation of these women, the dosing errors were the norm. So I think it's important. It might be useful for us to at least have a little sticker or a small A4 paper giving the correct doses of the drugs to be used in these emergencies. I talked about systolic hypertension. Very quickly about heart disease, I still have time. Heart disease, I ignored the demographics of the other things, but I wanted to highlight this one. The estate sector contributes a lot to heart disease deaths. So we need to focus our attention in these, and I think this needs special attention. So, so these are the causes of death. I really wanted to take this up separately. At the moment, the H512 does not have a tick for rheumatic heart disease. If you look at this chart, the main cause of death is rheumatic heart disease. That's the biggest category. So if we have a tick box to see whether somebody has had rheumatic heart disease, we might be able to detect some of these people and save them. This is not complimentary. 8.3, nearly 10% of the women had their lesion diagnosed at post-mortem. So, sorry, these things have not come here properly. So, if you take women who who can be expected to have an abnormality or the previously diagnosed heart disease, you take it off, it's about 30%, the women whose lesions are not diagnosed. So these are severe heart disease. So these are the women who died and it was diagnosed on post-mortem. Here's a good example. This is example number 6, the antenatal card H512. It's supposed to have been, a heart is supposed to have been examined 3 times during the pregnancy, and I don't think there is any way, it's a large AST, pulmonary hypertension and ischemia, it's very, very rare not to have this thing, but then the heart will be heaving and telling you that there is something wrong. This is something that I found. There is no record of a good cardiac examination that somebody had listened to the 3 sounds. There is no evidence in any of the tickets, right? So I think I want to suggest that we have a norm to have a good, solid examination of the heart. Just like Hutchinson's method says, it's very easy. You can do a heart examination within 30 seconds. If you're having the woman on the couch, turn her to the left side, put the stethoscope on the apex of the heart, and when she's getting down, you get her to sit up, lean forward, and listen to the herbs area and the other areas of the heart. It's a very simple thing, won't take 30 seconds. Peripartum cardiomyopathy is something that is missed very often, and we had 13 mothers dying of it. So I have a suggestion here for the Ministry of Health, and that is that when a midwife goes on a home visit, why don't we add the heart rate and the respiratory rate? Because a lot of these women, most of these, vast majority of these women, manifested the peripartum cardiomyopathy postpartum. So, and many of them had visits from the midwife. So if we had these, we can spot them earlier and bring them into the hospital. Say if we have a trigger for heart rate of 100, she shouldn't have a heart rate of 100 postpartum. There is something going wrong. Or a respiratory rate of 20 or above. It's a very simple, it's a low-hanging fruit. We can do something about it. Not only that, we can detect sepsis. In sepsis, one of the earliest things that changes is the heart rate. Anemia, the deep vein thrombosis, all those things can be detected with this intervention. So we talked about it. We had to be more serious about the proper thing. And this is another thing. There was one case where a lower grade hospital had looked after a woman with a severe heart disease, and she had a section done by SHO, anesthetized by an MO anesthesia. I think that's not acceptable. So the WHO classification must be taken into account, and women who have 3 and 4 grades must be looked after in a place that has physical multidisciplinary meetings with a cardiologist. So I talked about this. That's due to abortion. I want to again highlight the contribution of the estate sector. Again, to highlight the civil status, we have to give contraceptive advice, irrespective of the marriage, etc. That's due to pneumonia. It's very quickly, I'm running out of time here. A lot of them, the majority had the nasal swab taken, but really it would have been better to have the thing, the higher figure, but I think maybe these women came in the evening or in the night. The oseltamivir were given only to 2/3, so that's a failure there, and then where it was given, maybe it was a bit too late. So I just want to leave you with these ideas. So we need to address the quality of care issues, the high cesarean section rates, high induction rates, etc. I think there should be criteria for mandatory call to the consultant. Like say, if somebody is getting an unplanned blood transfusion, it should be informed to the consultant. Somebody is having a fit, there should be a call to the consultant. There should be criteria for mandatory presence of the consultant. So the responsibility should be with the ward staff. The consultant must be summoned and told, and this should be documented. I think a lot of these mothers would have lived if they had called the consultant earlier. I think for the hospital to institutional sector, we have to bring in accountability, and KPIs must be agreed upon. It can be done. Other countries have done it. This is from the UK, the maternity dashboard. This is something of interest, might be of interest to you. Look at what they are saying about cesarean section rates. Say at the top here, if you say if a section rate, hospital has a section rate of over 30%, they are saying stop admitting there, send them somewhere else. So that has quality issues. That's the UK. So some things for us to think about. Another thing for us to think about, are we delivering, are we using our human resource adequately? That is one thing I will talk about in a moment. Near-miss reporting, except for hemorrhage, is not wonderful. This is a plea that I would like to make to the college, to talk to the colleagues. Many times, particularly in hypertensive disease, women with HELP syndrome, heart disease, on anticoagulation, women with severe pulmonary hypertension, they were done by SHOs. That's not acceptable. I think the consultant must be obliged to do that. So like in the women who were treated in the emergency unit, there should be a way of summoning appropriate staff. The consultant, even a woman who is very ill, must come there, and I think we can save women like that. We must think about the EMOG training. We had a program, but it's not happening now. So this is what I was talking about. I want to really leave you with these ideas. So I think we need to think about common labor rooms. We can't have labor rooms in every corner. I think those days are gone. I said I was in New Delhi yesterday. One of the things they are doing to address high cesarean section rates, believe it or not, they are opening midwife-led labor rooms, midwife-led units. They are opening midwifery training institutes, MTIs. They have, I met 2 of them, they are getting midwives from the UK to come and train these people. So they are getting, to talk to some of them is very inspiring because they have taken respectful care to another extreme, right? They are saying they're just starting it. It's something worth watching. Shouldn't we try to increase the direct consultant cover? Let's take a consultant with 5 units, a hospital with 5 consultant units. The consultants are obliged to be on site from 8 to 4, 8 to 12, 2 to 4. I hope I'm right. Yes, 6 hours. So you have 18 hours where the woman is in, laboring women are in the hands of junior staff. I think we can improve that. I think we need to distribute those consultants because they are the most precious resource we have. Are we using them well enough? And we are not bringing down the maternal death rate. We have to think, I think we are stuck with the 1950s healthcare delivery model. Think about it. We are just continuing that. And now it's time for us to change. Please think about it. So, and I think there's no point in opening units here and there in small places hereafter. Please focus on expanding existing units. If you want to take a woman from one place to another, we have a wonderful ambulance service. We can use that. So I really think there is no reason to be starting small units. I think I have gone just about 3 minutes above my time. Thank you very much for your patience hearing. Thank you for the opportunity. Thank you, WHO.
Thank you very much, sir. Next in the agenda is the maternal suicides. A qualitative analysis will be done by Professor Thilni Rajapaksa.
Good afternoon, and thank you very much for having me here, and my acknowledgement to the head table. I'll be talking a little bit about maternal deaths from a different point of view, the issue of maternal suicides, and just to make sure that I'm not going over time, okay? So what I'll really be talking about is based on data collected extensively by the Family Health Bureau. So we'll be looking at 2 aspects: the quantitative data that the FHB has collected from 2003 onwards, which is a lot of data, as well as something more interesting that they did from 2017 onwards, the maternal psychological autopsies, to look at factors associated with maternal suicides. So just to remind ourselves what a maternal suicide is, it's the death of a woman by suicide, either during pregnancy or up to 1 year postpartum. So it's that whole broad period. And when you think about the concept of suicide, obviously it's an act where the woman has died, but she has died because she has deliberately done something, either poisoning, injuring herself, something, and she knew that it might end in death. The degree of suicidal intent could vary. Now, having said that, let's have a look at what we see from 2003 onwards. From 2003 to 2019, 465 women died due to maternal suicides. And you can see the number per year varies somewhat. It seems to be about 25 women a year, and that's been relatively constant with some fluctuations. This looks at the number of maternal suicides per 100,000 live births. And the lowest we've hit is 6 per 100,000 live births, but we've had a high of about 13 at one in 2010. So, as Professor Sennaika mentioned, every death is a tragedy and it should be prevented. Now, this is looking at the rough demographics. A majority of women who die due to maternal suicide are in their mid-20s. Having said that, there is a slight overrepresentation in the extremes of age, in the teenage mothers and the mothers over 35 years of age, which is what you see internationally as well. and a majority of them are married, though there is a small group of unmarried women. Now, when we also looked at where these women are coming from, which parts of the country, now this shows you from 2003 onwards. If you look at the whole number, it seems to be more Kandy, Kurunagal and Nuwara, but that's the whole over the past decades. What we did was we looked at the number of maternal suicides per 100,000 population, and that shows a different story. When you look at it per population, from 2015 onwards, we are seeing a clear distribution where the maternal suicides are much greater in the north and the northeast, where it's all the socioeconomically deprived areas and post-conflict areas. So that's what we are seeing. Braticlo, Trincomalee, Jaffna, then moving on to places like Monragala, Hambantota, Anuradhapura. So that's a clear message that we are getting there. And when you look at the ethnic distribution, I mean, obviously it follows the pattern of the distribution of the country. The majority were Sinhalese, but there is a slight overrepresentation among the Tamil ethnic groups, which reminds me of a former presenter spoke about infant deaths being higher for Hindu parents. So here we are seeing a greater number of maternal suicides in the Tamil group. The Sri Lankan population has about 15%, but the maternal suicides are about 20% Tamil mothers. Quick look at the methods used. Overall, from 2003, if you look, the methods used were mostly by self-poisoning. This just reflects the methods of suicide in Sri Lanka over the past decades. But now, the most common method is by hanging. The most common method of maternal suicide is hanging, as is the most common method of suicide in general in Sri Lanka. But there's one thing I'd like to draw your attention to, the red pie, part of the pie, 21% self-inflicted burns. So we see this self-immolation or self-induced burns in maternal suicides. So if you, now this chart just shows you, compares how non-maternal females die by suicide and how maternal suicides die. The blue line shows you the maternal suicide methods. And as you can see, when it comes to women who are pregnant or postpartum, they are more likely to use violent methods like setting fire to themselves. We don't know why that is. This is seen internationally. Perhaps it's the distress, the extreme psychological distress that they are in, or the hormonal changes. We don't know why. But self-burning is more common in women in the postpartum period particularly. They also follow hanging. And we see this in Sri Lanka as well. If you think about when these women are dying by maternal suicides, in the past decades, it seems to have been more antenatal suicides, but from 2015 onwards, it's more postpartum. Perhaps it reflects the improved antenatal care, I don't know, but we are seeing a shift. And for us in the postpartum period, it's the first month that we saw the greater number, first month postpartum. Internationally, they talk about more postpartum deaths towards the end of the postpartum year. Now, I'm moving on slightly to a more in-depth exploration of these deaths. This is based on the psychological autopsies that the FHB initiated from 2017 onwards, where and this has been done throughout the country for after every maternal suicide, where after the maternal suicide, a team of people, usually the PHM, a medical officer, and a consultant psychiatrist in the district, would approach the family tactfully within the first few months of the death and explore the factors that might be associated with the death, both psychosocial as well as an evaluation of whether there was any psychological disorder, either diagnosed or undiagnosed, in this mother who died. And so the information is synthesized and it's conducted using a particular tool, the psychological autopsy tool, which is called the PAMS. And I'm presenting the data from the PAMS from 2017 onwards. And this is one thing we looked at. We looked at, did the mothers who died by suicide, had they attempted suicide before or self-harm before? And we saw almost one quarter had attempted self-harm. And it was either missed or assumed to be the woman was just trying to frighten somebody, or it wasn't important. So now this is a clear red flag that we can use, just like our previous speakers mentioned. There may be, certain points that we identify as high risk. So if a woman has a history of self-harm, especially recent self-harm or during pregnancy or postpartum, that's something that can be picked up. We also looked at psychiatric morbidity in these women who died by suicide during the antepartum or postpartum period. Now, the 15.3%, the red part of the pie chart shows you that about 15% of these women who died by suicide were diagnosed to have a psychiatric illness. The blue part, the 31%, were found to, on retrospect, after the assessment, the team concluded that the woman had been suffering from a psychiatric disorder, most often depression, but it had never been identified. It had never come to help, never come to services, so this woman had had a change of behavior over several months, indicating depression, but it had got missed. So now that's again another place where she's fallen through the cracks. And that's somewhere we can approach and think about when we talk about prevention. And if you look at the whole, it's about 45 to 50% who have a psychiatric morbidity here, which is still less than what the West will report. The West will say up to 90% have a psychiatric morbidity when you have a maternal suicide. So I don't know whether this is still an underestimate. It could be. Some of these pregnancies were unwanted, but there were the reporting of trying to harm themselves or trying to end their pregnancy or harm the baby was very low. I don't know whether it was not reported or those rates were really low in these women. Now I'm moving on to, so the psychological autopsy looked at things like previous self-harm, then and psychiatric morbidity. They also looked at the psychosocial stressors, and this was reported in a more open format. And I'm going to quote some of the, it led to a qualitative analysis. So we did a qualitative analysis of the associated psychosocial stressors, and we came to several themes, several clear themes emerged related to these women who died by suicide. And I'm quoting directly from some of the PAM's records that we received from the FHB. So one clear factor seems to be this issue of marital conflict, financial difficulties. So this is a 27-year-old woman who died by hanging 6 months after delivery of her child. And it was reported that she had conflict with the husband because of his extramarital relationships and domestic violence and also financial issues. So you can see it's always very complex. It's never one factor. It's often multiple stressors that a woman will be having and the family will be having. And it goes beyond health. A similar situation where another woman who died by hanging, marital conflicts, extramarital relationship related, and financial stressors. I'd like to highlight there, she has made several attempts of suicide, often after conflict with the husband, which was picked up as, the family interpreted it as her just being upset or trying to frighten the husband or manipulate the situation. Again, a possible red flag there. The other aspect that came up with the marital conflict was often alcohol misuse in the partner, leading to domestic conflict, domestic violence, and sometimes associated psychiatric morbidity. Again, here another example of a woman who set fire to herself 10 months after the delivery of her first child. So long-term conflict with the husband related to him being intoxicated. On one occasion after an argument, she has become extremely angry and run out and set fire to herself. There was also a history of depression in this woman. She had been previously picked up, referred for services, started treatment, and then stopped. The follow-up she just got lost for follow-up. And you can understand how that happens because there's problems in the family, poor social support, and probably lack of awareness of this importance. So she was lost to follow-up at the time of her death. So just to highlight again that we are losing some of, although we are identifying women with depression in the antenatal and postnatal period, the follow-up or maintaining her and keeping her under observation and ensuring she receives support seems to fall through the cracks in the months following identification. And I think this is one place that we can definitely work on. So here, the woman who died by hanging has been diagnosed to have depression, severe depression, but her medication was not continued, and she also, the family had limited understanding about the issue, and she had been lost to contact at the time of death. Similarly, another situation where the woman, this is slightly different stressor, an unplanned pregnancy. So a 26-year-old university student who set fire to herself after her delivery because she, again, this was she became pregnant prior to marriage. And here we see another issue where withdrawal of social support, where the family were initially supportive, but when she became pregnant, they withdrew support. So lack of social support, unwanted pregnancy, pregnant while unmarried, all those psychosocial stresses together with previous self-harm in this context. A similar history again in the PAMS, where a 24-year-old woman who committed suicide in the context of an unplanned pregnancy and conflict with the husband. For some of the women, we saw other more long-range factors, like a 24-year-old woman who had committed suicide by hanging, and it was noted that growing up also she had been exposed to severe childhood adversity, financial difficulties, probable domestic violence, and this is something we know with regard to suicide in general. Significant childhood adversity, particularly physical violence in childhood, which is fairly common. We have lots of families where children are growing up in the context of domestic violence. So childhood physical adversity and physical violence is associated with adult depression and suicide. So, and there were other factors that sometimes also came up in the PAMS, like reduced support from the extended family, impulsivity in the woman herself, loss of a loved one, particularly one woman committed suicide after the death of her child. The baby died, and a few months later she killed herself. So where does this leave us? So I think what this represents is suicide in general and maternal suicide in particular is a very complicated, it's associated with lots of complex psychosocial issues as well as psychological disorder. If I sum up what we found in general about the maternal suicides, these were women in their 20s, though the extremes of age were more represented, and now they are dying more by hanging. But we also see other violent methods of suicide here, particularly setting fire to themselves. And we get a slight preponderance of postpartum suicides rather than antepartum, though it happens in both stages. And up to about 45%, at least according to the PAMS, have psychiatric morbidity, at least depression, and many of them are lost to follow-up. And the background context seems to be a whole lot of multiple psychosocial stressors, particularly marital conflict, domestic violence, alcohol use in the partner, and financial difficulties. And a lot of these are happening particularly in the north and the northeast part of the country, though it's, of course, island-wide. Yeah. So where do we go in this context? What can we do? Now, the problem with suicide, it's such a complex phenomenology that one solution rarely will reduce suicide. So if you break it down into steps, enhanced screening is certainly a very important part, but what do we screen for? Do we screen only for psychiatric morbidity, I think that's not sufficient. You also need to look for psychosocial stressors. Having said that, there'll be lots of, the number of people with psychosocial stressors will be great. So how do you follow them up? What do you do when you screen them is the next question. I know when it comes to now at the moment, the public health midwives, I think, have been asked to do the Edinburgh depression scale. And I think at the moment there is a proposal, and we are working on having the public health midwives also screen women for psychosocial issues and have a system of, have a grading of the psychosocial stresses that you're screening for. And once you screen, you can't stop there. It needs to be followed up by a system where there has to be a system where you can refer the person and provide appropriate intervention. And some of this intervention might be, say, if it's depression, might be referral to a psychiatry clinic and appropriate treatment, but some of it might be domestic violence or marital conflict. So it's beyond health. So do we need to link with other services? Do we need to link with social services, for example? Do we need to engage social workers in the community, or do we need to engage other potential services to support or follow up or provide support for such women and families? I think these are things we need to think about. Also, continuing awareness about psychosocial and psychological issues among healthcare professionals and in the community. Just knowing about depression in the antenatal and postnatal period, being aware that if somebody is threatening self-harm or attempting self-harm, it's good to mention to the PHM or seek a bit of advice, and also how to get help. So these are some of the recommendations we might want to think about. Improved screening, having a system of referral and intervention, and also thinking about innovative intervention which goes beyond health. The problem with maternal suicides is that it's a very complicated issue. It's part of it is the illness part is in a way easier to manage. So the psychiatric morbidity can be treated, and we need to ensure that what we are seeing is at the moment people are being identified and referred for treatment, but they are lost to follow up subsequently, and some people are missed. So we need to correct that. But then there are lots of other factors associated which may go beyond health, which needs multidisciplinary, I think, working with other services to ensure support for such people. And ongoing monitoring and follow-up of those at risk. So it's really a multidisciplinary identification and follow-up and support that we need. So I think I'll stop there. Thank you.
Thank you, Tilni. Maternal suicides has been and is an untouched area even at global level, but as a little country, we have done a lot. So the final presentation, please bear with us, then we will be moving on to the panel discussion. It's done by Professor Indira Kitulatta. She will be talking on the maternal autopsies. Over to you, Indira.
Thank you, Kapila. And I want to thank the Director, Maternal and Child Health, Dr. Chittamal De Silva, and Dr. Manjula Dhanansurya for inviting me to do this review, important review, and also everybody who is present here. I think this will, even though you all are clinicians, this will give some insight to you the importance of the maternal death autopsies and getting the findings out of that for prevention of maternal deaths. So I am going to skip the first few slides where all of you have talked. So from the results, I am going to talk. We have reviewed 1,335 maternal deaths during the period of 2011 to 2019, which had been reported to maternal death surveillance response system. And out of that, in 573, that was 55%, postmortem reports were available. And 306, we could extract the data regarding the postmortem from the case scenarios of maternal death, the surveillance system. And there were 57 cases where postmortem had not been done, and there were 10 cases, 10% cases, that was the 99. Postmortem report was not available, only the cause of death report, cause of death that finally at the end of the autopsy we issue the cause of death form, that was available. So out of these 156 cases where no postmortem report, that included that 57 cases of where we have not done the postmortem, 10 cases what happened was no details available whether postmortem done or not, and 89 cases with no findings. So when it comes to the provincial and district-wise distribution, and the majority was from the Colombo district where the most highest population was, and that was 17.8% of the maternal deaths during the period. And in the second was the Kandy, it was 13.9%. And most of these cases, the death has been confirmed in a station where VOG is available. That's above a provincial general hospital. That means maybe they have been transferred to that hospital finally when the death was confirmed. So when we looked at the progress of the disease of these cases, majority, that was 66%, had a slow progress of the disease, and where 63.2% had been admitted to the intensive care unit. However, there were sudden deterioration while in the ward in 21% of the cases, and there were sudden death at home 3% of the cases, and there was other cases that was few. So according to the maternal death surveillance response, it was suggested that the post-mortem should be best done by a specialist in forensic medicine. However, it was only 66% of the cases the post-mortem had been done by a specialist in forensic medicine. And also we can include the MD qualified non-board certified specialists also into this category. There were 5%. They are acting as acting consultants in some other stations. The sad thing was that there were 14% cases the post-mortem had been done by an MO with no diploma. I'm not worried about the MOs with diplomas and the registrars and senior registrars doing, because those cases are directly supervised by a consultant, because they are in, most of the time they are in a consultant station, so they will be doing it under direct supervision of a consultant. So the concise report format which Kapil had shown, that Dr. Vaidyaratna had designed, had been introduced to report on maternal deaths in 2013, but up to 2013, most of the cases report was not available to the maternal death surveillance response system. After 2013, they have started reporting in that concise format, but still the majority had reported in the Health 42, which is the regular post-mortem report, which is we use for all the homicides and other natural deaths as well. So the findings included in the post-mortem report was most of the important things were there regarding the internal examination and the organs, about 70%. However, the summary of the clinical findings, which is important for us to come to a final conclusion, was not there. Only in 33% of the cases it was there. The basic information was there in 82.9% of the cases, but those basic information may be name and age, so the preliminary, which is a requirement for all the postmortems when they report, maybe not that relevant to come to a conclusion regarding the maternal death. The preliminary details like scene findings, which is not relevant here, was not that reported, but the presentation history, which is important, how the mother was brought and how she was presented, that was also not recorded in the post-mortem report in 33.6% of the cases. Out of the external examination findings, the findings of natural pathology, we will be documenting whatever the findings of natural pathology available externally, like jaundice and the pallow. These things are not recorded. Even the absence should be recorded, negative, important negatives, but not recorded in recorded only in 31.8% of the cases. But the post-mortem changes had been recorded in 75% of the cases, which is not that relevant in a case of maternal death. That is because it is the regular format is having a column to record the post-mortem changes. So when it comes to the two types, especially the two types of reports where people had used to report the maternal death findings, clinical presentation findings were poorly recorded in both concise report and Health 42, but it is little better in concise report, it was above 50%. But the post-mortem changes and the clothing, which are not relevant, had been very well recorded in the Health 42. That is because there are areas for us to record these things in Health 42, but in concise report they were not there, but that is not important. The nourishment of the mother, it was poorly recorded even in the concise report, which is designed to report on maternal deaths. It was only 30% was recorded in nourishment of the mother, and in Health 42 it is much better, it was 81.5%. The findings of natural pathology was poorly recorded in both forms, and findings of medical and surgical interventions, concise report showed only 41.7%. But in Health 42 it was better recorded, 72% of the cases it was recorded. Now, when it comes to the compatibility with the final conclusion arrived at the maternal death mortality review meeting and our cause of death, both concise report format and the Health 42 format, they have considered equally when they come to a final conclusion, 60%. So other recorded findings, So most of the time the fetus and the placenta was not available. It was not much well recorded. Now for the preliminary details, where they have obtained these preliminary details is not recorded in the post-mortem report in 62% of the cases. But 23% had that recorded it as bed head ticket and other clinical records. The preliminary interview, what we do when the case is brought, we talk to the relatives and the police. So that is, from that we have obtained the findings in 6% of the cases. Ancillary test, which is very important, because the maternal death or whatever death, most of the time these natural deaths, the gross autopsy findings are not only the not that good method of coming to a conclusion, because you can have lot of artifactual things and non-specific findings, that is people record pulmonary edema and these soft spleen and all these things, but these need to be confirmed through histopathology. But histopathology was the highest, highestly done ancillary test, but still it was done only in 66% of the cases, where report of histopathology was available only in 47.6%, and report had not been there in 18%, even though they have done histopathology. Other investigations like microbiology, little bit better done, but it is only in relevant cases you have to do. But the best thing is for every case to in natural death, every case to undergo histopathology is a must if it is to be done into the with international standards, but it was not well done here. So positive findings we have observed most commonly in the respiratory system. That does not mean the cause of death was in the respiratory system, because almost all of them finally die with respiratory problems. And then we had findings in the cardiovascular system, gastrointestinal system, that was mainly the liver, and then cardiovascular system and the kidneys and the genital system. So these were not necessarily the cause of death, but the findings finally when they died. So maybe multi-organ failure and all these organs were affected. So affected organ and the clinical summary. Clinically, even though we have not suspected that these organs are affected, at autopsy we could find almost all the organs were affected in a higher percentage than the clinical suspicion. Now, the basis for the cause of death by the pathologist commonly used basis was antemortem clinical picture, antemortem investigations, and comprehensive autopsy including ancillary tests. This, which is the gold standard. This is the thing they have to do. Not only by the gross autopsy, ancillary testing should be included, and they have to review antemortem clinical picture and the antemortem whatever investigations available from the BHD, all to be considered to come to a conclusion. That had been done only in 30% of the cases. And in another 30%, clinical picture with antemortem investigations and gross findings, but no ancillary testing had been used. The sad thing about is that there is 4% of the cases, which is shown in this purple, Antemortem clinical picture only was the basis for come to a conclusion of cause of death. That was a defect from our side. And there was 1% where the clinical picture and gross findings only had been used. So we have to address these areas in our system. So justifiability of the cause of death according to the reported findings or available all the findings, it was good that 60% of the cases the cause of death was justifiable according to whatever the reported findings. But in 15%, cause of death was inconsistent or not compatible with the findings recorded in the postmortem report. And in 10% of the cases, cause of death only consistent with the clinical or circumstantial findings but not with the findings they found at autopsy. So, contribution of the autopsy findings towards the cause of death, majority had a potentially fatal acute pathologic finding that which was identified, and with the clinical pathological correlation and the history and exclusionary findings, that was considered as the cause of death. Potentially fatal acute pathological findings. But only 14% had definitively fatal acute pathological findings, that was ruptured uterus or ruptured ectopic pregnancy with large hemoperitoneuria. So that definitively fatal acute pathologic findings were available only in 14% of the cases. And there were 7% cases where definitively fatal acute pathological findings on top of chronic potentially fatal pathological findings were observed. And there were 14% of the cases with definitively fatal acute pathologic findings are identified. However, underlying pathology leading to it was not identified at the postmortem. There was 5% of the cases, no pathologic findings are identified at autopsy, and also clinical pathological correlation also could not give a good conclusion regarding the cause of death. So 5%. This is something which is expected if the postmortem had been done by a qualified person. If it has been done by a non-qualified person, they will always give a cause of death even though the cause of death is not available. Slightest narrowing of the coronary artery will be ischemic heart disease. So this 5% is something which is expected. Here. Okay. So compatibility of the clinical findings with cause of death given after autopsy, it was compatible in 81% and somewhat compatible in 12%, however not compatible in 2% of the cases. Then maternal death mortality review meeting and our cause of death compatibility was 71%, and there was a little bit discrepancy in 19%, not compatible at all in 7% of the cases. So without being judgmental, I would like to bring these two case scenarios where the non-compatibility was observed. I don't want to read it because I don't have time. At autopsy, where the cause of death was abruptio placenta, probably concealed type on accordance to history. But according to the maternal death mortality review meeting, it was amniotic fluid embolism. And this is another case At the autopsy, the cause of death was amniotic fluid embolism following partial tear of the uterus due to assisted childbirth. They saw histopathologically fetal squames in the blood vessels, but no thromboemboli seen in blood vessels. But the cause of death at maternal death mortality review meeting was pulmonary thromboembolism due to deep vein thrombosis. I don't know why this discrepancy is. The basis for the opinion of the cause of death and the qualification of the doctor when it comes to the qualifications, even though it is majority had been done by the consultants, the most of all of them had the similar percentage of cause of death being based on the best evidence like antemortem clinical picture and also the total comprehensive autopsy and the investigation. And justifiability of the cause of death also, when it comes to the board certified specialist, it was 62% was justifiable cause of death given, but MD qualified not board certified, that was younger consultants, had 71% justifiable, but it was not that significantly high, but it was higher among the younger consultants. I think the reason is they are more based on mostly the ancillary tests rather than gross findings to come to a conclusion. Younger consultants are much better in that. And the proportion of the cases where autopsy was not performed, it was highest in the Colombo district number wise, but the percentage wise it was highest in the Ampara district, which was 16.1%, followed by 15.2% in Colombo and Batticaloa 13.2%. So we recommend to ensure the regulations are adhered to, where the cause of death should be performed by a consultant, that regulation, at least under a direct supervision of the consultant, it should be performed. Where the consultant should be countersigning the cause of death report, then he is accountable for the findings. So he has to supervise. So that has to be, I think, advised that counter signature of the consultant to be done. And also you need to have regular reviews and update the guidelines on performing autopsies among the forensic expertise. So the college will have to play a role there, and monitor the timeliness of and feedback of the postmortem reports, and we have to ensure regular CPD activities, especially the newcomers, and minimum standards, especially ancillary tests. This includes histopathology to be, I think it should be a must. And the discrepancies, when there is a discrepancy of the cause of death given by a forensic expert and finally at the maternal death mortality review meeting, these cases we suggest to be reviewed by another independent review committee. Consists of maybe forensic experts as well as the specialists in obstetrics and gynecology, because the discrepancy, why it happened. And the multidisciplinary approach, where the support of the other clinicians, other laboratory clinicians in the hospital to be obtained to maternal death investigation, because some of these cases where histopathology had been done, the reports not available at the time of the report is sent, at the time they have sent the report to the maternal death mortality review system. That was because histopathologists are not giving the priority to the deaths. Actually, it is the thing which is happening, because clinical cases they give the priority. So that since it is a maternal death, need of the support of the histopathologists as well as microbiologists and other laboratory specialists to be taken. That was multidisciplinary approach in maternal death investigations. So to capacity building, also similar things, and the circulars and guidelines, And regarding the quality of the report, the concise report needs to be improved. That from the to include the findings, we have mentioned that we need more. We have to improve that concise report. Then the concise report format can be used in future without using Health 42 to report on maternal deaths. I think that's all. Thank you.
Thank you, Indra. I think one of the quality dimension in Sri Lanka's MDSR is the mandatory postmortems, which is always appreciated by WHO and other professional organizations. Now it's the high time to have the panel discussion. I cordially invite President of the Perinatal Society of Sri Lanka, Dr. Samant Kumar, to come to the head table, and all the presenters to come to the front seats. Professor Tilni, come here. Dr. Nishani. Unfortunately, Dr. Sanath Lanrol had to leave for an urgent matter at the SLCOG. So to start the panel discussion, I would like to invite Acting Director General of Health Services, Dr. Panapiti, to start the discussion. So from there, you can give your reflections, and then we can open the discussion.
Yeah. Thank you very much, and very good afternoon to you, all of you. And we should actually convey our sincere thanks for the Dr. Susi Perra, DDG and Deputy Director General Public Health Service 2, and also the Director Family Health Bureau, Dr. Chito, and also the National Coordinator for the Family Maternal and Child Care, Dr. Kapila Jayaratna, and for the arranging this important forum and inviting for us to participate actually. Not only for this one, so we have to appreciate the services of the Family Health Bureau actually that are maintaining and conducting the services during even the COVID period, and also after the crisis situation, and with the not only that, actually with the support of all the hospital directors, all the relevant consultants, and all the relevant categories of hospital staff actually. So then so far actually that we have maintained there are some increase in the maternal deaths, but due to the COVID situation, but anyway that we are managing our services to a certain satisfactory level. Okay, so then actually death is a case for us in the health service. It's an event for us, but it's not like that actually for the families. So then amongst all the deaths, actually maternal deaths is somewhat much more important, because actually death of a mother is affects to the family and as well as actually all the children. So then the educational, economical, and social, all the aspects. So then that's why actually that this forum is very much important. The initiated during a very fast period from 1981, I think, no? And so then nowadays our Directorate Quality and Safety also that has taken initiatives to conduct organize medical audits. So then this is one of the medical audits so initiated even during a very fast period. And with this audit system, and also that the very effective preventive health care, preventive public health system. So we could have achieved many indicators actually that in comparing to the even to the other developed countries actually. These indicators actually, so then you have seen, so then it has been drastically from the 1980s, so then it has been drastically came down to a satisfactory level. But so then we see all the indicators are stagnating nowadays, so then during this current period. So then the review findings identified gaps are very much important to decide actually, that identified the ways to going from this to the desired level. So identified as the objectives and the targets in health for all, that universal health coverage. Okay, so then that's why this type of forums are very much important. Actually, not only that, actually, apart from the DG's role, acting DG's role, today DG has attending another important forum. So then I am actually participating. I prepared to actually be participated here as DDG MS1, because actually though this service is organized by the Family Health Bureau, this is one of the key important role actually you are giving support to us for the medical services. So then that's why we both of us actually, Dr. Vijay Surya DDG MS2 informed me, so then he is attending another important meeting at the Treasury, and myself and Dr. Athapattu DDG, Director Tertiary Care Service, and Dr. Ayanti, Director Medical Services. So we are all here actually. So then you are giving us a good support, and all the provincial directors, regional directors, and the hospital directors. So then, so we want to improve the clinical governance in our curative care setup. So then you are giving good support to us. So then that's why actually we are here. And we saw there are so many reasons for the maternal deaths and the infant deaths. And those are summarized actually into three categories, three delay models. But for the administrators, actually we have only two categories of causes. So the preventable causes of preventable deaths and causes of unpreventable deaths. So then, and we want you to actually that together, that all the stakeholders are here. So then, if you can, today I think this forum won't be able to develop such a, or discuss and develop such a comprehensive plan. But anyway, that as soon as possible, so then identify according to the summarized gaps and identified causes. So then develop a plan. So I invited actually Dr. Landroll and also Dr. Kapila to develop such a get together and develop such a plan. So then please give us a plan. So with the able our hospital directors and the provincial directors and regional directors, we will be Director General of Health Service and also the from the medical services. We will be able to actually give our fullest support for that, because without having a medical service support, we this won't be able to achieve, because actually most of the time hospital directors and the provincial directors, regional directors, actually they will follow the instructions from the medical services. So then that's why I requested several times to come and we'll discuss. So then, but we couldn't get it done. But anyway, that in future, so then we'll be able to actually do such a effective way to identify the causes and provide very productive solutions. So then, and not only actually give the solutions to be implemented those in the institution with the help of the all the relevant specialties and all the relevant staff categories and with the guidance of our directors. Okay, so then I think so then if we could have time to discuss each case individually, so then we will may I think better, but anyway that we don't have the time, so I remain here because so in future I think we appreciate if you can develop such a comprehensive plan and submit to us, so then together both services, so then we will implement those. Right, thank you.
Thank you very much, sir. Madam Dr. Susi Perra, Deputy Director General of Public Health Services, your reflections, please.
Okay, thank you. I know it was a very exhaustive presentation, so many presentations. I think the objective here today is to look at the different data sets, and I think that is what the different resource persons from different Dr. Lanarol, and if you take from the UOG side, Professor Hemantha Senanayaka, then from the pediatricians, I think Nishani, and the forensic pathologists, the forensic side. These are different data sets that we have that are available to understand better how we can, and of course, yes, the psychiatrist side, because we have to see how we can bring down the maternal mortality and also the survival of the children in this country. So these are different data sets that we have been looking at, and WHO has quite rightly asked or supported the analysis of these people have actually presented today, giving the Family Health Bureau another view of its existing system to support, to see where we can fine-tune and further reduce the maternal mortality. That is what we have been listening. It's a lot of information, and I was trying to wreck my neck trying to understand because it's very difficult to see that. And I think this data should have been given to us. And I'm just thinking, not trying to be sarcastic, but the amount of money that we spent on this event today, getting all of you here, and you have been very patiently trying to witness this data, and this is the public sector, right, looking at all this data, trying to improve a situation. I think I can remember, I recall, and I was telling Dr. Chitramali also, in 2019, just before the COVID, when we analyzed the maternal mortality, the end of that year, 2019, and I was actually telling that we must have a strategic plan to reduce the maternal mortality by 50%. And actually, from the data that was presented, I was thinking, how right I was at that time, if everyone had pursued on it, we can do it, because it's pointing to that. I'm not agreeing with Dr. Lanarol, who said that you can bring it to 1-digit figure, but 50% reduction is possible from what I understood, from what each and everyone has been pointing it out, right? And that's possible. So it's a collective thing, from the field to the clinicians to the hospital administrators, and there is a part that everyone can do, and 50% reduction is possible. I think that is what I can see. Of course, I took a few notes here and there. I'm not going to bore everyone from what is being said. And of course, I think Dr. Kapila, he started off by saying that there is a change needed, but he didn't because in his presentation he also said that Sri Lanka's record, and it's highly commended the mechanisms that we have in Sri Lanka, and said that there is a change needed. So I couldn't quite understand why he mentioned in his presentation. And then, of course, when Dr. Lanarol mentioned something at the end, pointed out saying that confidential inquiry, and it didn't kind of connect up either about a confidential inquiry. He's not here now, I don't know whether he's in the audience, but I think this data, the presentations, has to be looked at very carefully in a much more serious way, not just ending up with a nice lunch or anything like that, but the amount of money spent on today's this thing, and also the amount of money that has been spent on all this analysis and everything, justifies much more take home on this, serious to be serious, and we have to go for a 50% reduction. That is what I can see from this, because this is not just a kind of a pep talk here, because data is for action. And what we reviewed here is the analysis, the data mechanisms, and I'm very thankful to all the presenters who have contributed to that understanding of myself, that we can go for a 50% reduction. Thank you very much. I had more notes, but I'm not going to
Thank you, Madam.
go on this.
I think we all agree 100% what you said. Now it's over to Professor Goni Lienege to give your reflections, especially on infant mortality and child death reviews.
I think in terms of infant and child death reviews, I think we are somewhere there. I mean, we are pretty good. We have evolved since 2006. Still, I mean, we have a long way to go. So I believe that when it comes to death reviews, it should be at local level, the immediate death reviews, which are very important in terms of service provision for these kids. And also it should be at a later date, at national level maybe, with the involvement of the stakeholders, other parties, other agencies. So both could be done, because I can give you a great example about the dengue infection, where we had in the height of epidemic, maybe around 2010, 2011, we had so many deaths, and now we have come down, the death rate has come down drastically. We are very good. The center I'm working, at Colombo South Teaching Hospital, where we are in the mid of a very highly burdened area of dengue. So we are, for the last 4-5 years, I can't remember a death happening in a child who's infected with dengue. So that's a great example. So I think the initiation of this desk review specifically by Dr. Chitramali and Dr. Kapila last year is good initiative, so that we can work towards that, we can understand the circumstances, we can identify the systemic issues, the issues in service provision, maybe at local level, national level, so that we can take action. And also specifically in local reviews and the desk reviews, there had been a little bit of here and there complaints. I think we should not misplace our focus. We should always focus to propose solutions and then to implement, rather than going for a fault finding mission or fact finding and trying to find the fault and all that. We should always keep that in mind. I think it's great that if at a central level even workshops or even webinars can be conducted, how to conduct a death review constructively. And also when I went through Dr. Nishani's presentation, we know there are a lot of gaps and there are issues which should be improved. Like for example, prematurity, we have to look at very seriously. We have to empower our staff, and we have to see why the death rate is high, infant death rate, because of as the root cause being prematurity. So we have to now, as Dr. Susie said, I mean, we have lot of data now, so it's for us to start working on this. This is more than enough for the next couple of years for us to intervene and start our journey to become better in the future. And also, I would suggest, I mean, when we are planning our intervention, it should be, we all should keep in mind about the economic crisis, what the resources that are available, and as much as possible, those interventions should suit the current circumstances. Thank you.
Thank you, Guani. Actually, I appreciate your words. Unless we disseminate this data, it would have been just a kolagoda. Right now, we have added value to these data, and now available, we can work on it. So I cordially invite Dr. Saman Kumar, President of Perinatal Society of Sri Lanka, to give your reflections.
Good afternoon. Thank you, Kapila. And first of all, I would like to thank Family Health Bureau and Kapila especially for inviting me. And I congratulate Kapila and the team and the Family Health Bureau and all the presenters here who did a wonderful job to present the data. I think data is extremely important because we have been going in the dark without data. We need to know where we are to proceed. Without data, we can't do anything. Data is extremely important, so very good that we have data. I'm a neonatologist, but both mother and the baby equally important for us. I will mainly concentrate on the neonates, but I have a little point to clarify with maternal mortality data presented here. And it was presented like the more deaths were reported in teaching hospitals and the district general hospitals. We know that most of these mothers are transferred from peripheral hospitals, and some of these mothers, when they are transferred, they are in bad shape and probably can't save their lives. And also the private sector, the mortality rate was extremely low. And we know that some mothers are transferred from private sector when they are in bad shape to government hospitals. So do we know whether this very high mortality in the teaching hospitals and the district general hospitals, whether they are their own patients or whether these patients are transferred from other peripheral hospitals. I think this is something that we need to clarify, and I would be actually very happy if it was presented in that kind of description about this maternal deaths which took place in the highest centers in our country, because otherwise it will be a bad reflection of the management of the teaching hospitals and the district general hospital or the higher levels in the country, and I think that's probably it's better to clarify. About the neonatal mortality, I have to say, as the first neonatologist in the country, as the senior most neonatologist, I am still confused with the definition of neonatal mortality rate, because there's serious problem in terms of reporting. Now, I have to say, we have to be very realistic. We have to know where we are in terms of neonatal mortality rate in our country. And I'm sure you may be able to remember, it was even discussed, presented in the parliament, saying that in Sri Lanka, the neonatal mortality rate is comparable to the neonatal mortality rate in the USA, which is absolute rubbish. We are nowhere close to USA. And this is very dangerous to say that we are having a very low neonatal mortality rate, and then there's nowhere for us to go. We have to understand where we are. And what is reported in the international platform is neonatal mortality for Sri Lanka is 4, which is absolutely rubbish, absolutely wrong. And I very clearly presented when I was elected as the president-elect for the Perinatal Society. I did 1 year study covering the whole, because I wanted to plan my year, whole Sri Lanka, including all the district, and my sample included more than 50% of the real national level sample, which demonstrated, or which I realized the neonatal mortality rate was 8.9%, which is still underreported because we could not get any deaths which took place in the labor rooms or the theaters. So, and there's real problem when it comes to reporting. Are we reporting deaths less than 28 weeks? Even today, yesterday, the neonatologist from, I have to mention, one teaching hospital complained to me that the VOG is not allowing to report the deaths before 28 weeks. So we have to report any death before 28 weeks by definition, although it is an abortion by definition, this is a neonatal death. And Nishani very clearly mentioned the neonatal death is a death of a fetus which is born with signs of life. But are we going to take 19 weeks fetus who is born with signs of life, are we reporting as neonatal death? By definition, yes. And we are reporting at Castle Street Hospital, even a 21-weeker, 22-weeker, if the fetus is born with signs of life, we are reporting as a neonatal death. But this is not realistic. Before 22 weeks of gestation, it's not compatible with life, and we can't save that baby. So are we, in one end, we are over-reporting in some hospitals, right? So 21 weeks, 22 weeks, we are reporting as neonatal death. Is it realistic? Because this baby is not going to survive. So we have to make a line, we have to draw a line. We are not going to report as neonatal deaths before this certain gestation. I think that is very clearly mentioned in one of the documents in Family Health Bureau, that this 28-week business is there. But when it comes to definition of neonatal mortality, so if fetus with signs of life, we have to report as a neonatal death. So one end we are over-reporting. The other end, and some hospitals, less than 28 weeks, we are not reporting. So where are we going, what are we going to do in terms of, because less than 22 weeks we can't do anything. And even 23 weekers, I have to say, in my study we realized that nearly 100% mortality, and only few babies are surviving. So this is, we have to draw a line whether which gestation we are going to report. If we want to compare with the rest of the world or region or the world data, okay, we may have to report 22 weeks. But in that case, we have to make another allowance. Now in Sri Lanka, even a baby who is born with anencephaly, we report it as a neonatal death. And critical congenital heart disease, which is not compatible with life, once the baby is born, we report it as a neonatal death. But can we compare our data with other countries? Because other countries, you don't, I mean, these things are diagnosed antenatally, and these babies are not born. And this severe or very, what should I call, the congenital abnormalities which are not compatible with life is not seen in other developed countries. So can we exclude these babies from our data, from our calculation? So I think we were talking about achieving neonatal mortality rate of 2.2 by 2030, which will be a dream if we don't address these things. We need to have a cutoff gestation before which we are not going to report, and we need to discuss what we are going to do with this critical congenital abnormalities, babies, whether we are going to count them as neonatal deaths. So I think these are important things to discuss. And also, please, we need to educate our obstetric colleagues that we need to report definitely below 28 weeks. Thank you very much.
Thank you, Saman. Thank you so much. I invite Dr. Ramani Pallemulla from the Sri Lanka College of Anesthesiologists and Intensivists to give.
Kapila, thank you very much for giving me an opportunity to give my opinion. What I have to say, as Dr. Saman mentioned, the high death rates in teaching hospitals. That I also noticed. I agree with him, totally agree, because the deaths are higher in major hospitals, most of the time due to transfer cases. Because when mothers are critically ill, they are being transferred to hospitals from private hospitals. We at Castle Street, we tend to get a lot of transfers from private hospitals. And by the time they come to our hospitals, they are quite bad, in very bad situation, and we can't do much actually at that level most of the time. So that is agreeable. And regarding hemorrhage, that is the number one cause of maternal deaths now in the year 2020, according to the data shown. So again, most of the deaths we can see in relation to placenta accreta, percreta related deaths, and these deaths are actually totally preventable if identified earlier and transferred to hospitals with all the facilities and expertise to manage these cases. Whereas the other hemorrhages, like other postpartum hemorrhages due to uterine atonia and all, those are unanticipated hemorrhages. We need to improve our identification, the monitoring, post-operative or post-delivery monitoring with Meo's charts and all will help to identify. Most of the time these cases were identified late when the mother is collapsed and then rushing to the theater. So that was actually too late. So this Meo's chart maintenance and identifying the critical level, I always tried to highlight in these death review meetings when we had discussions that it is not only monitoring, maintaining monitoring, it is very important to identify the trigger levels and then have the responses accordingly. So it is not just monitoring or observation, this track trigger response system. That is very important. So triggering and then appropriate responses are, I think, very, very important. I think we have to improve that area in all our, peripheries, as including teaching hospitals. Even Castle Street, I have to say. So, and DMH. So I think anyway we are very happy to see that the maternal mortality rate is coming down slowly. Of course, we have to target for as Susi said, 50% further 50% reduction is possible if we work hard and have understanding and try to implement all these, suggestions or your recommendations. Thank you so much.
Thank you, Madam. I could invite Dr. Chitramali D. Silva to, get the inputs from audience.
So thank you very much. We should get the comments from the audience. Maybe we have the different categories, provincial directors, regional directors, the hospital directors. Can we get the views of you all regarding the findings presented and the recommendations?
Yeah.
I see hands up there
sorry.
also. Sorry, Kanishka.
Sorry. Just one point. Although you might wonder why I'm here. I'm a gynaecologist, but I came because I was the past president of the college who succeeded Professor Hemantha Senanayake. There were very few very important terms which many of the speakers used. One thing was quality of services. Other thing was safety, risk management, and then stagnation were repeated by many, many, many speakers. Stagnation of our death rate for the last 2 decades, especially with regard to maternal mortality. This has been discussed over and over again every year. And although I had a huge plan to do something for oncological field, but I was forced to change my idea because this maternal mortality was a problem at that time. So I took the statistics and flew to London and had a long discussion with the Royal College of Obstetricians and Gynecologists, and they went through the statistics. And they come up, and there was Scottish College of Obstetrics and Gynecology, Royal College, and luckily there was a meeting with the Rangscock, means the Australian and the New Zealand College of Obstetrics and Gynecology, and they came up with this new concept. I think Dr. Panapitiya mentioned, adopt clinical governance. That will quickly bring the next year, 2 years later, you will see the results of it. It will quickly drop the maternal mortality down. Immediately do it. We had the same problem in late 1980s. Scottish College, we had the same problem in late 90s. And the Rangscock, that means Australian College, also said the same way. We came, we all sat down and prepared a clinical governance process. And that to be implemented in stage-wise. And we submitted that proposal to the Ministry of Health to start with the labor room practice. We'll put the labor rooms under the clinical governance process because that was the area which were very concerned. The reason for that is maternity service is a public service in this country, except for few deliveries we do in the private sector. Public service has several components. There's a public health service, field service, then the hospital services, which include normal wards, labor rooms, and then intensive cares as well. So many aspects in the field. Put all services under one umbrella. That's what the clinical governance is all about. We put all services under one umbrella, and then that will maintain the transparency, we are all in one team now. The field, the hospital services, all are in one team, transparency, accountability, Professor Seranayaka just mentioned, and the quality and the safety. So in fact, the former DG was very supportive at that time, and we put up that plan to the Ministry of Health to implement, starting from the labor rooms. That is the only way out. Otherwise, we'll be discussing this over and over again, and even after 10 years, if we meet again, we'll be discussing the same statistics. And this is the time our country, because we have a very strong public health program. Our field services are so strong, and mortality rates at this stage. That is the only reason that we are keeping it so strong. And if we add clinical governance into this, we are through. We will break all the barriers, and within 5 years, we will reduce, as Dr. Susie said, we will get 50% reduction within 5 years. I'm 100% sure about it. I'm 100. The quality of monitoring the patients in the ICU, monitoring the patients in the wards, all come under the clinical governance process. Everything will come under the clinical governance process. No one can escape. Maintaining of charts to monitor, everything comes under the clinical governance process. Why I'm saying is that during 2016, when I was a president, we did a survey. Partograms are maintained in only 5% of the hospitals in this country, sir. Partogram. We are printing partogram in thousands, but not maintained. And we are talking about quality of services. So I'm not saying we are bad, we are good, but we need to improve ourselves further. That is what I'm saying. So unless you bring the clinical governance process into this specialty, I'm very thankful to Dr. Panapitiya. We will be stagnating even after 10 years. If he happens to meet like this, we will be the same. So this is what I wanted to speak, and we have done it well. We have done the roadmap, and the ministry has it. I think we college also have it, and we are ready to implement it. I'm sure our future presidents will implement it. Thank you.
Good afternoon, everyone. I am Dr. Rifaz, RDHS Kalmuni region. I would like to share the experience what we have in our region, and it is rather administrative than clinical, but we have to look into the both sector. In our region, we get medical officers, the post-intern medical officers, just after passing the intern, they come to our region, even to the bigger or the lowest hospital. Where those interns, most of them have never exposed to the pediatrics or maternal or gynecology, gyn-ops wards. But they are appointed in a periphery without any proper training or experience on this case. So during the fuel crisis, we had a case, the mother admitted to a base hospital, Type B base hospital, where there were no consultants available by that time. The MO attended the emergency, the delivery. He doesn't have any exposure to the maternal or pediatric cases. So unfortunately, we lost the baby, and mother transferred to the tertiary care center to Ampar. The issue is this is continuing as a relay. They come and stay as a 2 years. Is it considered as a difficult station? So they come and stay 1 or maximum 2 years, and they go. Then again the same group come. What I wanted to tell here, the people who are coming in the lower in the merit list. So most of them are foreign graduate, never exposed to the delivery or any cases. I would like to consider this the able forum, especially Panapitiya can consider, at least with the college, we can have a training to all medical officers, at least 3 months training on neonatology and gyn-ops and emergency. Otherwise, we have doctors, but they have never exposed this kind of emergencies. So as it was really enlightenment of this presentation. I'm thanking everyone who had made a wonderful presentation here. And there are some other issues we can discuss individually, but this is one of the major issues we find. So we have to have a regular setup to train people, not only the eastern province, wherever they are going to the periphery, north or anywhere, they have to have exposure to this field, since they have gone only for two major field in the internship. So I think this forum is a good forum to consider this, this proposal, and thank you very much for the opportunity.
It was actually that your idea is well taken. Actually, we were discussing about that previously, the College of Obstetrician and Gynecologists. So then they initiated that such a training program for SHOs and MOs, so in the peripheries. So then that's why we requested to initiate again that forum, that training. And also that we will we have idea actually that before placing to a place, so then if they don't have such a training before in the internship, during the internship, so then give a at least 1 month training before placing to the station. Okay.
Can I say
so
something?
Then
Sorry.
Yeah.
Sorry.
Okay.
I don't know. I hope I didn't interrupt you. But I just want to say this training, we had a training to run from the Ministry of Health through the Family Health Bureau, and we trained 700 odd people, but with the COVID coming in, it stopped, and also now, so we can restart it. I have been calling the Family Health Bureau and offering my services. I was the course director for that. I am very willing to do it. We used to run a 2-day course actually, which was very useful, and with a bit more support, we can do a better job, really. Thank you.
I think that's a very valid point he raised. Even for neonatal mortality, the neonatal mortality rate is extremely high in that region, the north and east.
Part
and
of our course is neonatal resuscitation.
Yeah, so we as neonatologists, we are ever ready to train them. We can absorb them to our units and train them for maybe 1 month or even 6 weeks or whatever.
Actually, people don't know how to use an ambu bag. That's
Yes,
the problem.
yes.
So
it's a shame, sir. It's a shame. We need to do that. So I think we have to restart it definitely.
Hemant, what you mentioned was the emergency obstetric training course, but they are requesting is a longer term. I think there should be a streamlined program for training them in the obstetric unit. They won't see the partogram maintenance and the Muse charts all with practical training. I think before they go to a peripheral unit, at least to attach them to a tertiary care or wherever a consultant supervised unit to get the training, like our registrars or whoever they get in the training in our units. Yes. So the college, more than the college, actually the ministry can organize, and the obstetricians working in those units can help actually do the training. Yeah. You can send them to the teaching hospitals, the units, rather than the college giving different courses. Mostly the practical experience they get.
Yeah. That's why
I am Professor Karunagaran, working in the teaching hospital Batticlo more than 22 years. What I found is we have so many data and everything, and also data must be taken and audit must be done with history taking an examination. There are a lot of shortcomings, especially, what Professor Hemant mentioned about the pulse rate, blood pressure, respiratory rate, auscultation of the heart, are the interns doing. Many of the time, most 99% of the time, medical ward, surgical, in obs and gynae, auscultation of the heart is not done nowadays. And as mentioned by the professor, there are wrong information on the antenatal card as well. This must be strengthened because the consultants, working physician or surgeon, must be looked into this, especially the interns, taking a proper history and the examination. Otherwise, we keep on having a static rate of maternal death, and that will be continuing. Unless this strength area is not strengthened, even when they are going to the peripheries, they are not going to do a good job. We are going to miss a lot. Near misses are going to happen. So an audit must happen on this aspect as well. How much the interns are doing this auscultation of the heart, a proper history and the examination are they doing. Especially after COVID, they fix the patient onto the monitor the monitor shows on the pulse and the blood pressure and the oxygen saturation. Those are the only thing appearing on the BHT. Not auscultation of the heart or respiratory rate, nothing is happening. So please concentrate on this, very important. Thank you.
Yeah, couple, can I speak? Yes. Now I would like to congratulate all the speakers. The data were very nicely analyzed and very nicely presented. And now I think we have started this program is very important. And what I can say from my point of view is now about 47% of the deaths are preventable deaths. And while working in Castle Street of Hospital for women, we have seen some mothers, some women who should not get pregnant, they are presenting with pregnancy. Now, some women, they are contraindicated for pregnancy, like in WHO 1 and 2 category cardiac mothers who are having cardiac lesions. They should not get pregnant, but they are not properly given, they were not properly advised for contraception. But they are getting pregnant and coming in, they end up in our hospital with complicated cardiac pregnancies. So I think we have to, the SLCOG will have to advise their membership for proper contraception for those mothers who are having contraindications for pregnancy, and not to let them pregnant without proper assessment by the cardiologist.
Thank you for your comments. I don't know, it's too late to go on discussing many things. There are so many things to discuss. I don't know whether there are any more comments from the audience. So anyway, yeah, thank you very much, I think, for your participation and active contribution in the discussion. So we are to now move forward. Right? So there are a lot of findings with detailed recommendations. So I think under the chairmanship of DDG PHS, we will have maybe some technical groups and to discuss the way forward, and also to prepare some sort of a concrete action plan based on the findings that we got today, right? So I think these findings are very important for us to maybe go for 50% reduction of preventable maternal deaths and also the preventable neonatal and child deaths. So we can work very closely with all the professional colleges and then with the hospital administration and the preventive health sector. So I hope with the support of the development partners at the UNICEF, WHO, UNFPA, all three were here. So we can get their support also for future actions. So we will have some very concrete action plan and to move forward. So I think that should be the way forward. If we go on discussing, we can discuss a lot. But anyway, I think you have to think of the clinical governance, as the many speakers said, improve your supervision, improve the quality of care programs in the community setting and also at the hospital setting, so that we can reduce some of these preventable maternal deaths as early as possible. We know that all of us are now in a very critical situation due to financial cut down. So there are a lot of shortages of supplies at the hospital level. Amidst that, we had to work and provide some sort of a quality care, and also there are a lot of human resource issues are coming up because of this crisis situation. So I know all of you are doing a wonderful work to improve your MCH services. I hope that will continue and we will work together to improve it further. So thank you very much for your contribution, and also I thank all the resource persons who did this analysis and did wonderful presentations. And I must thank our Acting Director General Dr. Panapitiya who was here throughout in spite of very busy schedule, and also Dr. Susi Pereira for guiding us and being present with to take some recommendations out of this meeting. So all the colleges, college members really acknowledge your presence, and all the provincial and the district teams, the hospital administrators, and the consultant community physicians, MOMCHs who are present here with us from all the districts. So thank you very much for your presence today, and I thank Kapila and the team and my team also for your excellent contribution. Thank you very much. So we will maybe meet one day with the concrete action plan, and maybe we will take your positive actions for its implementation. Thank you.
Yeah, one big thank to the Tamarind group for all the audio visuals, and the BMICH staff for their contribution. Thank you.